السلام عليكم ورحمة الله.
السلام ورحمة الله وبركاته.
هلا دكتور ماهن وهلا بالجميع الحقيقة. We'll start in 1 minute.
الله.
السلام عليكم everybody.
عليكم السلام ورحمة الله. هذا دكتورة جيهان الله يسلمك. hello دكتورة شادية, how are you? Welcome. عليكم السلام ورحمة الله. Welcome everybody.
Thank you very much.
السلام عليكم ورحمة الله. الحمد لله والصلاة والسلام على رسول الله خير خلق الله. This is Dr. Samir Abdurrahim Sindi, the chairman of the Saudi Ghani Endoscopy Group and the chairman of OB-GYN department in Abdurrahman Al-Mishari Hospital and Continuous Medical Education. First, I would like to say this is our webinar on the last Friday before Ramadan. So happy Ramadan to everybody. And this webinar is unique in multiple reasons. First, it's under His Excellency Dr. Mahmoud Yamani. He is the board director cluster for Ministry for Medina, and it's before Ramadan. Also, on the same time, it's Medina have a lot of barakah, so it reflects on the number of participants. Until now, we have more than 2,000 participants sharing from every part of Saudi Arabia. Also, on the same time, our speaker from different parts, from international and local speaker on the same time, from different generation, from young generation like me and Dr. Rehab, and from all generation like others peoples on the same time. I would like to thank all participants who are sharing with us during the Friday. All of them, they have going to have HCME. I would like to thank Al Mishari Hospital for their sharing with us for CME. Thanks to Saudi Medical Specialization. Thanks to supporting company. Thanks to Bayer, thanks to Cure for their supporting company, and Rose Al Jazeera. On the top of that, I'd like to thank Top House Conference for supporting us and for recording all of those participants, and with the good video with their support. Thank you very much for everybody. I leave the word to Dr. Mahmoud Yamani. Thanks for him to join us. It seems that he's going to join us with his voice now. It's actually, he's so beauty and handsome. So now he's not appearing his picture because of the technical problem. Welcome, Dr. Mahmoud Yamani. Hello. Dr. Mahmoud. Dr. Jihan, you are with us?
أيوة دكتور.
Yeah. I spoke with Dr. Mahmoud. He has a technical problem only in the voice, but he will join us soon. So do you like that? Meanwhile, I would like to say that we have HCME, and all the participants, they are going to receive the HCME in 2 weeks time. So it's our pleasure that all participants are joining us. So meanwhile, I think if Dr. Mahmoud is not with us, do you like us to represent the first speaker, Dr. Hisham Arab, until Dr. Mahmoud will join us? He was with us now. So do you like to represent first Hisham Arab?
So Sarah, start دكتور.
Yeah, please.
Okay. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. كل عام وانتم بخير جميعا، والله يعيننا على الصيام والقيام ويجعلنا من المقبولين بشهر رمضان بإذن الله تعالى. Okay, this is my honor to start to be a chairperson in this first awareness day, which is under by name of Medina, in the presence of His Excellency Dr. Mahmoud Yamani, the chairperson of the board of Medina Health Cluster. And my honor also to present our godfather, Dr. Hisham Arab, who he is the godfather of gynecologists in Saudi Arabia, especially in Western area. And he is the director of fetal and women health program in the Dr. Arab Medical City Center in Jeddah. He's a consultant of reproductive medicine and endocrinology and minimally invasive surgery. His first talk will be about endometriosis awareness in Saudi perspective. So, Dr. Arab.
I'd like to first welcome Dr. Mahmoud Yamani. Now he is with us. So if you want to give us some word from Dr. Yamani, so we'll have more barakah from Medina Munawwara.
Jazakallah khair, Dr. Samir. First of all, I would like to thank the organizing committee and the scientific committee for holding this webinar. This is a very important subject that that actually affects not only ladies, but also the new generation of people coming to this world. It is a very important timing for such a webinar. This is the last Jum'ah before Ramadan. May Ramadan be a blessing month for all of us and all of you guys. It also gives me a great pleasure to thank the participants in this webinar, both the speakers as well as the attendants. And as always, a special thanks to Dr. Samir Sindhi for putting all of this effort together. And again, for every person that has participated in the organization and in the review of the scientific scientific subject of this webinar. This is a learning platform that we have seen the physicians in women health use extensively to the greatest benefit of humanity. So thank you very much again for everybody that has participated in bringing this to life. With that, without further ado, I will ask the scientific committee to start the scientific meeting.
Thank you very much, Dr. Mahmoud. It seems that the number of participants above 2,400 until now. So I'd like to ask the first speaker to start, please.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على أشرف خلق الله محمد بن عبد الله صلوات الله وسلامه عليه. First, I'd like to congratulate everybody here about the forthcoming Ramadan inshallah. جعل الله من المقبولين والصائمين وتقبل منا صالح الأعمال. First, I'd like also to thank Dr. Samir Sindi, Dr. Jehan Al-Hazmi for their really kind invitation and introduction. It's a great webinar, and I hope we'll benefit from it. Can you see my slide clearly, Samir? Dr. Jehan?
Yes, clear.
Right. The webinar is actually talking about women health awareness, and I think, in my opinion, maybe I'm a bit biased, endometriosis awareness maybe come as one of the major awareness efforts that should be carried out in women health. So to start with, I would say I like this cartoon. You know, it says there's a big elephant in the room sitting on a couch here and saying, "I am right there in the room, and no one even acknowledges me." So imagine it's not the right place for an elephant, and it's so huge, but nobody's noticing it. So this is exactly what we are dealing with endometriosis. The strange thing about endometriosis is that it is common. Well, it is about 10% of women of reproductive age having endometriosis, and the presenting sign of it is pain. So who can really forget about pain, or not to mention about pain, anything about pain? And the strange thing about this is really it takes long time sometimes to diagnose it, up to 7 or 10 years to diagnose a case of endometriosis. So the pain comes in different formats, whether it is a chronic pelvic pain, and 80% of those have endometriosis, or just simple dysmenorrhea, and about 60% of those, they have dysmenorrhea. So it seems to be that this is a problem that affecting a woman in the prime years of her life, and the symptoms is pain. Now, if you look at this pie diagram, you can see here about in 20% almost below the age of 20, and another 46% between 20 and 30. So more than 2/3 of our women actually having endometriosis in less than 30 years of age. And the other thing is that with the symptoms of dysmenorrhea, only 5.6%, 30% of them, they actually seek a medical advice on this. Well, why? Is it because they don't know anything about endometriosis? Well, this is what Deborah Bush from New Zealand, actually, I met this lady when she published her original work, she's just looking at the like secondary school there and for girls, and I just asked them a question: do you know about endometriosis? And here she plotted according to the different states of New Zealand, and even to the best, only 40% of students in New Zealand know about endometriosis in high school. So she started a project to introduce the menstrual health program in New Zealand. And the conclusion of that project, in 2 years later, when she published her work, she found that it increases awareness of endometriosis, actually promote the timely presentation of women to specialized healthcare services. So you don't want her to suffer for a long time. Bring her to school, bring her to the care of doctors so they can at least help her instead of going into a long time with suffering. So this was really a big, important, impact that happened in New Zealand. What about Saudi Arabia? Okay, well, there are lots of publications about dysmenorrhea in Saudi Arabia, and this is one of the recent ones coming from Al Jof University. They're looking all at the girls in Al Jof University, included about 366 students participated. And you can see here actually the effect on daily activities in this population is very remarkable. The 87% reduced their activities, concentration, 48% affected by endometriosis, social activities, domestic activities, and even the attendance to the university has been affected by about 1/3 of them. So this is a huge number. What I did actually with my group, we have done maybe looked at a bigger size population, all girls unmarried, attending high school or the first 1 or 2 years of college. And here we have about 2,400 girls included, and under the age of 20. And then we have seen here the distribution. You can see that it is the majority between 16 and 17 years of age. That's 1/3, another third below the age of 16, and another third which is really between 18 and 20. So they given the questionnaire, and out of that we have seen that the time of occurrence of pain usually of dysmenorrhea has been varied. They actually reported about 88% of them having actually dysmenorrhea. So this is how common this dysmenorrhea in our country, in our region. Literature reported between 70 and 91 even, and more than 70% of Saudi girls have it during the first 2 days of menstruation. 14% actually went to see a doctor. Only 14%. And those who had seen a doctor, 55% had transabdominal pelvic ultrasound. Out of them, 4% showed an ovarian cyst, but none of those cysts were pathognomonic of endometriosis. Right? Endometriosis. What about endometriosis in Saudi Arabia? I have really come across a study where they looked at every single publication about endometriosis in Saudi Arabia, and there were only 10 studies. Out of these 10 studies, 2 were retrospective studies looking at the gynecological laparoscopies, and they identified the disease there, endometriosis. 5 were just case reports, and actually the 2 were related to the infertility and other things. There is one study, the bottom one here, it was included in this literature search, but this is actually is an Egyptian study. Actually it was the author was working in Saudi Arabia and he published out of here, so we cannot include it. But the more important 2 studies that I can really allude to as a Saudi publication reflecting the endometriosis in Saudi Arabia is the one published by Dr. Abdurrahim Rozi from King Abdulaziz University here in Jeddah, 2015, followed by Dr. Samir Sindi's study published from Riyadh King Fahad Medical City. Of course, you can see here the numbers. Rozi included only 190 patients. Sindi included 595 cases in his study. And they looked at laparoscopic gynecological surgeries. And then out of those, Cindy identified 14% to be endometriosis, while Rosie identified only 11% to be endometriosis. So we can have a range here about 13% of endometriosis prevalence in hospital-based population. And you can see the incidence of pain maybe a bit varies, it depends on the pathology, but the infertility background is more or less the same between the 2 studies. Now, I want to introduce ECAP. ECAP stands for Endometriosis Coping and Awareness Bundle. Well, this is my invention. And here, what we see is that it's a bundle of procedures, techniques, packages, and plans to help improve the management outcome of endometriosis. Well, I created this to help endometriosis patients coping with the painful attacks and lead a productive and optimistic lifestyle. It is a tailored duty work during work days or outside the working activities, and it is somehow can be tailored to any place you can apply this ECAP. It requires a teamwork led by the primary endometriosis laparoscopist. Now we don't say I am a gyne laparoscopist. Now you have to say I'm an endometriosis laparoscopist, because actually there is a difference, and maybe we've seen it over the years. And an endometriosis educator. You know, there is a diabetic educator, whatever educator, we need an endometriosis. So these two are the minimum requirements to run ECAB. And of course, more physicians, nurses, volunteers, and surgeons can be involved to run the whole thing. Well, I hope the publication will come out sometime during this year, because it's been sent for publication now. Now, before the aim here, or the objective, is that when you see a woman having endometriosis, suffering from an endometriosis attack, she suffers the pain. She suffers also the medication side effects that she's taking to relieve the pain. She suffers from tuberculation, and also the panic at the time when she get the pain and start to lose control. Our aim here, actually, with the application of ECAB, actually, is maybe the woman, she has that attack treated, maybe the endometriosis hasn't been treated, or partially treated, but her coping technique has let her to know when is the attack is coming, and to accept some modification in her life. In addition, she'll have a self-control over it, and she will not panic, she will not lose control on this situation. For that application of this, actually, I always address the doctor first, because I'm a doctor and I think there is a lot of responsibility rely on us. I love this painting by Luke Filders from London, where a doctor looking at a sick girl there, just watching. As if the painter telling us doctors, listen to her, give her the time to explain, don't scare her, and establish a clear plan of management. So this is exactly what we need for endometriosis. Now, scaring her and saying, oh, this is endometriosis, you're gonna be infertile, you're gonna lose whatever. Well, it's not really something that a good doctor will do. Why? Because scaring technique is usually reflecting a compensation of ignorance, a compensation of lack of management. But we have all the facilities now and all the techniques, the medications to help these girls. So all what you need is to really to be calm and reduce her anxiety and depression, and also to mention some good stories. Of course, all of us maybe treated endometriosis, and you see a woman with endometrioma has collapsed, or she got pregnant very efficiently after a short period of treatment. So mention these good stories and not to go over the bad outcomes. Now, there is also an indirect role of the doctor that really being put responsibility on, which is here divided into two arms. One is the patient education, and under this, they will have two actually activities: the increasing public awareness and hospital-based programs. And the other arm is the patient support group. Again, this can be led or supervised by the doctor, all right, the endometriosis specialist or laparoscopist. And under that comes the social media and other techniques. For the public education, teaching the teenagers about endometriosis, about severe dysmenorrhea, it's really what you do is utilizing patient education materials, whether it is written, videos or videotapes or books, and trying to explain the whatever available knowledge available on this, but also looking into the face-to-face or one-to-one interaction is essentially important. You have to highlight how important for her she joined this, important to participate in her school activities. How to write or educational material on this is very simple, and has been published, and this is just a tool I included here for you to see. And then comes the hospital focus program. The hospital focus program or BASE program, usually actually it is psychoeducational interventional design to facilitate adaptation to the challenges of chronic diseases in general and promote self-management. For chronic diseases, this has been founded long ago, more than 10 years, 15 years ago in UK, for example. And it has been shown that for chronic disease in general, participants found to be less anxious, less depressed, and score better on all of the self-management techniques after self-management training. They actually felt more in control of the disease. These are some of the quotes that I have really put it here. And for example, this lady, after attended a hospital focus program, she said, I think has been a great help as I feel safe in controlling the panic now. So now, how these can be really applied? Well, here is an example, actually, of a recent publication from Iran. It is a hospital-based program they have introduced with self-care group counseling, conducted in using in a native language using the ORMS self-care model, which is a well-known scoring system, and that has really used as a measure of your activity. What it involves is really 7 weekly sessions. Each one lasts about an hour and a half, and usually conducted in a relaxing, friendly environment. They included about 76 patients in this program. And this is the list of different topics they have discussed over these 2 months. You look at the outcome. It's great. The scoring system of quality of life of physical health has improved. The scoring system of the quality of life of mental health has also improved with statistical significance. And it's really increasing a lot. The anxiety score has dropped remarkably with statistical significance also. Depression actually scoring has dropped, but it's not really significant, but maybe the group is smaller. However, it is something, it's showing that there's a great tendency here to have a better life after applying a hospital-based program. When it comes to the patient support group, there are measures, the group of patients that they have, it seems to be they have shared the same medical problems, offer a form of comfort and encouragement. It's non-profitable and it's a free enrollment, and it's not really costing much. However, it has been supported sometimes by different government or associations. It tells you here how to lead a support group. You have to be listening, you have to be assertive, you have to know the effects, the facts, and also to make it fun. What is the benefit of this patient support group? The major 3 benefits of this is, number 1, knowing you are not alone. Because when you look around, you see other people who are suffering the same thing. So this is very important fact you can grasp. Learning new coping techniques. Maybe you're new to the disease, but others had it for maybe another 5-6 years. They knew by experience how to deal with it, the attack. So they can teach you. You can learn from them. And also sharing the experience. Maybe you know something that you'd like to add to their experiences. So here also using the other group, the other way of getting the knowledge, which is the internet. Of course, nowadays we're using more internet than the in-house or in-person meetings. And it seems to be, according to health information access from the internet, in US, about 72% of women, they use it, while in UK, it's only 43%, less women using it. But look at the purpose. 25% access the link for the internet to find people's experiences of a health-related problem. 60% find others with the same problem. So it seems to be there is a reason for them to go on the net and to find out for somebody who has the experience. And the good thing about the internet is that flexibility, accessible at any time, no specific timing, like the meeting, I have to be there at 10 o'clock. No, even where you're lying on your couch at bedtime, you can have a look at the net and get some information. And the other thing is the lack of face-to-face contact can also help useful, which is less inhibit that kind of tension sometimes to go to meet a group or people that whom you don't know. And then internet, you get everything. Even you talk to other people sometimes on the net and have a Zoom meeting and without being shy or anything like this. So it has been also looked at carefully, and you can see here there is some benefits that has been gained, therapeutic gains, which is connection, exploration, narration, and self-presentation. It has been published in many places to find the effect of going on the net for endometriosis. Blogging is another thing, and I wrote about this actually, and how when the patient, how to develop a patient that can write about her condition. And especially for endometriosis patients find informational value in blogs and online discussion, especially for the effective support and the optimistic experience. Now, this is a tool that I actually presented at the European Endometriosis League in 2018, and just to show the technique how a group of women actually of endometriosis actually reach to the stage of blogging and talking about it on the net. Usually start with a search and formulation, whereas a patient with endometriosis start to look, get acquaintance with the literature. Then she start to look for people who know about it or know about the maybe information from certain sectors, from certain authorities or personal experience. So they share this information. After that, when she got this trusted information, readers start to think that it is useful and current and very effective. And this is what become cognitive authority. Now she's in authority to write a blog, to talk about it, to advise other women. So you see the whole cycle. It is something that extending over time, and it is part of ICAP, which we're gonna see in the future. I just want to conclude here with a very small, simple messages. Self-care and support group is not a TLC, it's not tender living care. No, it is something essential. This is a system that can take the management of endometriosis to a different level, away from medical or surgical interventions. Endometriosis medical care should include guidance on how to help those patients socially, sexually, and psychologically. The endo patient will no longer be a victim, but a victorious, who is in control of her disease and turning the endometriosis upside down. And finally, this is a slide I love to show because this is endometriosis awareness by my son. I call him Dr. Mohammed Mabrouk and his colleague Lucy. They established this endometriosis awareness video. Because of the time, I cannot really play this video for you, but I think this is what we all should do in order to spread the knowledge about endometriosis. And I thank you very much.
Thank you so much, Dr. Hisham Arab. As usual, very informative and very nice lecture. So our second speaker is supposed to be Dr. Mohammed Mabrouk, but I think he's still busy. He's not joined us yet. So we'll be second speaker with us, Dr. Maher Muaddin. Dr. Maher is assistant professor of at King Saud University Hospital Division of Urology, Department of Surgical Specialist, and he main hospital King Fahad Medical City Riyadh. He's talked now about tips and tricks in successful laparoscopic gynecological procedures. So, Dr. Maher. Please, before Dr. Maher will start, I want to tell the audience if they have any question, they can write it or type it in chat. So after first session, so there is 15 minutes to answer for the speaker to answer your question. Thank you so much, Dr. Maher.
بسم الله الرحمن الرحيم والصلاة والسلام على نبينا محمد صلى الله عليه وسلم. I would like to thank the organizing committee, Dr. Samir, Dr. Ghalida, and the rest of the members for giving me the opportunity. And this is the subject is really very, very long. I would like to squeeze it and probably I'll skip on the some of the slides, go through them fast. And I would like at the end to share challenging cases that you might face in the OR. Probably the audience can participate, or I just go through them quickly. So the talk today is about tips and tricks in successful laparoscopic gynecological procedures. Personally, I'm directing the robotic surgery in the Ministry of Health for the last 3 years. And my basic core, I'm a consultant urologist and minimal invasive as well. So we'll start with the indication of laparoscopic procedures. We all know it could be diagnostic or therapeutic. Diagnostic could be from endometriosis all the way to the chronic pelvic inflammatory pain. Therapeutic could be retrieval or reconstructive, like fistula repair or retrieval, any pathological organ. The complication has been classified according to the step of the surgery or related to the type of the procedure you are doing, or to the type of the organ involved. So I will select this more and zoom into more to it. Is the anesthesia related? I will not talk about this a lot because not our territory. And the probably more about the abdominal, vascular, GI, and GU potential complication. Very important steps need to be kept in mind when you are dealing or considering to be, or you are planning to be involved on minimal invasive laparoscopic / robotic procedures. Please, proper history is very important. If there is any previous surgery, the type of the pathology you're going to deal with, detailed physical examination, at least have a look. Sometimes we overcome this in a busy clinic and just wheel the patient to the OR, and you get surprised in the OR about the patient is having previous surgery. So you need to ask about this and examine the patient looking for abdominal scar, patient habitus, or the body mass index. Is very important to plan yourself. Consent, please consent yourself, your patient, for all the possible potential complications. This is very important, need to be considered. Proper, prepare other specialties as required. Communicate with them directly if you want them to join you in the OR. Check and recheck your updated images. This is very important. Don't keep it to the last minute on the date of the procedures, because you might get surprised and you cannot go back at that moment. Visit the OR yourself and check your instrument, the monitors, the recording system, the gas tank is full, the required consumable items is very important. So you don't get surprises in the middle of the procedures. Communicate very well throughout the procedures with the nurse before you start, the position you're going to put the patient at, what you are expecting, and what you might face potentially. Be in direct communication with the anesthetist at the same time. Patient position and the pressure area need to be padded. Put your required drainage tools, particularly the bladder, and as required central line per anesthesia. Be prepared for the possible complication, and good exposure is very important throughout your procedures. And please record all your procedures. There is, especially you are at the beginning of your career, and you want to build experience, because you will learn also from the steps that you've done in the previous, or mistakes you've done in the previous procedures. So throughout the procedure, you should think anatomical all the time. Be anatomically oriented. And how many times whoever involved in minimal invasive, they've been through the procedure, step to the room and you see your assistant or other surgeon, they're zooming too much into the structure. And that's keep you away from the potential damage might happen to the surrounding structure without being aware of it. So panoramic view all the time when you face challenge, stop and reevaluate, reassess is very important. Why? To be aware of the anatomy, to be more efficient, faster, more effective, and more confident and safer. Be aware of your superficial, like inferior epigastric, detail anatomy from inside is very important. Be aware of your laparoscopic pelvic anatomy is different from the open technique. The location of the ureter, the vascular plane, the internal iliac and cardinal ligament, the external iliac vessels, and the obturator vessels. Then this will take us to the port entry. Most of the surgeons worldwide, they need to the close technique, but there are, be aware of the other technique like open and other technique like optical trokers and radically expanding trokers like this system. So you put the needle here and you trokers on the top, and you advance. The advantage of this, it has blunt tip, so less likely to do potential damage compared to the regular technique. Or you can use the visual entry system. It could be disposable or reusable. And these are some of them, like OptoView, VisiPort, and EndoTip. The evidence for visual entry, it requires less entry force and it applied less pressure on the advancing the trocars, and it has less significant facial muscle defect with a smaller defect. Be aware about the potential peritoneal access challenges, including adhesion and obesity. And the patient at risk, obviously, the morbidly obese patient, very thin as well, they're at high risk for vascular injury, pregnancy, prior laparotomy, as we see, and previous pelvic or large pelvic or abdominal mass. So you should be prepared and aware of other port access. Being in the midline with the ferrous needle, myself, I shy away from that approach a long time ago. I go to the lower quadrant, small stab incision, and pass the needle. It's very safe. Or left upper quadrant could be alternative. You can use in a significant adhesion. You can use also micro laparoscopy to localize the adhesion site and advancing the other trocars safely. The other way, if you can use a visceral slide, asking the anesthetist if you are close to the upper part of the abdomen to hyperinflate the lung, to push the organs away from you or bring it closer. Use the peri-umbilical ultrasound guided saline infusion, and that will help in optimizing the dissection with the higher sensitivity and specificity up to 100% in reported studies. We'll move to the bariatric patient also. The closed technique, it might be challenging, and in those patients, keep in mind there is other alternative. Don't quit, don't move to the open, because it's really nightmare in dealing with the huge amount of fat throughout abdominal wall and the within. So consider transvaginal through uterine fundus if you have long ferrous needles, or trans-cul-de-sac gas insufflation. Some people use intracostal access, and myself, I never use this technique, but this is, whoever is familiar with this can be considered between the 9th and 10th intercostal space. So the ferrous needle is well known to most of you, the very low complication rate, and it has, it first described in the 30s, and it has two tips, blunt tips and sharp surrounding it. But once this clicking part is past the peritoneum, it click and give you clicking sound. So you have to do a checklist of the steps. You have to check the spring mechanism. The patient has to lie flat or Trendelenburg, adequate skin incision. Lift the abdominal wall before you insert it. Insert in the lower part of the umbilicus. You need to angulate based on the abdominal body mass index. Make sure that you are aware about the safety check, the aspiration, hang drop test, and hissing sound, manometry test as well. Most of you know these steps, and gonna go through them quickly. If you have challenges or a scar somewhere here, try to go to the Palmer's point. So that's make you away from the potential complication. But please, and I've seen this myself with the senior surgeon, when they put the needle there, they wiggle it right and left. And the problem of this is if you are inside the fissura or great fissures, that's make the 0.6 millimeter incision or ferrous needle incision to 1 centimeter. And then you really lose the control if there is a bleeding or you make the bowel injury significant. So not to wiggle the needle once it's there, in and out only. Safety test has to be checked, as I said, and direction of the entry need to be kept in mind. And I will highlight on this. You can pull the abdominal wall like this, and you advance your ferrous needle if you select the midline umbilical approach. The direction of the needle here, modified technique if the patient is less, body mass index is less than 25, then you can use 45-degree angulation once you pass the peritoneum to avoid injuring the great fissures. Because what's happened in the ultra thin patient, try to shy away from going in the umbilical direction because this is very, it might go to the common iliac fissures. It might be very disastrous. If the patient above 30, you can always go 90 degrees safely because a lot of fat pad in there. Make sure the pressure is high when you insert the first trocar, 25 to 30. And the steps need to be kept in mind in summary of those. Consider alternative approach in the high-risk patient. Check the safety points that I mentioned earlier for the ferrous needle. The incision infraumbilicus have 5 to 10 millimeter insertion of the ferrous needle with the angulation. As I mentioned, don't move the ferrous needle to avoid enlarging the injury. And you need to check the pressure and the insufflation during the insertion of the needle to ensure you're in the right space. And put the high pressure initially. Once you put the first trocar, do 360 degree to evaluate there is no damage has been done. This video will summarize whatever mentioned. I'm going to go through it quickly. You empty the bladder, patient position, you make your incision, be aware of the bifurcation in ultra thin patient and potential damage there. And the angulation need to be kept in mind when you pass through the 3 pop or 2 pop signs when you advance your ferrous needle, and then you put your trocars and do quick 360, then you position your patient. So moving to the next slide, the initial laboratory technique, ferrous needle, it might be challenging to pass. Change the position of the ferrous needle and keep in mind potential complication, mediastinal emphysema, momentum emphysema, and potential pneumothorax if you are high up. Another system needs to be considered, and this is very important, very interesting, very nice. I like it, especially when you plan to do big surgery, robotic surgery, constructive, large pelvic organ surgery. Consider, please, the air seal. The air seal is the new technology. It has the following advantage. It stabilizes the pneumoperitoneum, constant smoke evacuation. It has a value for free access to the surgical site, and it keeps the pressure maintained throughout the procedures. It has the advantage of smoke evacuation and standardize the insufflation mode all the time by itself. The trocar step need to be when you advance the first one. Myself, when I made my incision, I dissect with the hemostat. I go all the way until I feel the peritoneum myself to minimize the resistance when I advance the trocars. Make sure also the skin incision is wide enough to advance your trocars and not very wide to ensure there is no gas leak throughout the procedures. So it has to be wide enough to adapt your trocars with less forcing pressure. You can use this hand pressure technique, push the gas to the other side so you can advance your trocar, particularly the first one. The advancing first trocars probably go through them safely, and this is the air seal. It's showing that this is without conventional technique. And you see any suction there, it brings the pressure down. And see here throughout the procedure suction, no matter how much you do, it never comes the pressure down. So please consider the air seal when you need it in the big surgery. We'll move it now to the open laparoscopic technique, Hassan technique. There is not much to say, just ensure that you go layer by layers when you do this technique and not to grab the bowel when you advance the trocars. Optical trocar technique has been mentioned earlier, so no point of going through this. Again, be aware of your anatomy when you advance your first and second trocars is very important. How to prevent the potential complication. Now, you need to pay respect to the procedures, the technology required, and the technique that you are using, either insufflation, open technique, or direct insertion. Now we're going to move to the potential complication might happen with the laparoscopic procedure. So we're done with the port side, first port, first needle, open, or other techniques. And now we're going to move to the potential complication. So it might be GU, GI, or the vascular injury. The risk factor for GI bleeding, it's usually during the installation, and if there is adhesion or the previous laparotomy. During the surgical procedures is very high, it's particularly in endometriosis patient, or if there is a previous history of pelvic surgery. Risk factor, it could be mechanical or severe endometriosis. Be aware of them. Direct trauma due to adhesolysis or enterolysis, or could be thermal. And this is very important, need to be brought to the attention here. Whatever the modality of the instrument you're using, how much it is safe, please, when you dissect close to the bowel, dissect with the cold technique. Or make sure that you are far enough in order to use your bipolar, monopolar, ultrasession, etc. This is very important point. You better pick your pathology and re-evaluate the bowel again and again if you've done dissection close to it, to ensure that you pick it up intraoperative rather than when the patient presents late. The mechanical injury usually show up early compared to the electric one show up very late. And when the patient comes to the emergency or to the clinic and she is having pain, please listen carefully. I know we all have a busy surface, but please listen carefully. There is no harm of admitting the patient, investigate properly, and refer to the required subspecialty rather than using your ego and discharge the patient, and then you end up with the litigation in the court. Prevention of the bowel injury need to be, the tips need to be aware of. Use different transvaginal or transrectal ultrasound as required. Use the required images to pick it up, to prepare your procedures. Evacuate do EndoTube as required, vaginal packing as required, dissecting, etc. So urinary tract complication is the second one. Urethral and bladder injury, fistula is very high. So I'm gonna go through this. Ureteric injury is very high, particularly when at the fossa of the ovary or the uterine artery or the uterosacral cardinal dissection ligament. So you need to be aware of this anatomy. And probably this one, yeah. You need to be aware of the location of the ureter and is usually keep this statement in the mind. Water go under the bridge. So the water usually come under the uterine, that's the ureter. So when you dissect there, be carefully, dissect close to the uterus, dissect carefully, isolate the fizzles, and re-evaluate, revisit, and do intraoperative consultation, no harm before you do the damage. So the high-risk condition people, if you have severe pelvic endometriosis, large uterus, large ovarian mass, cervical or intra-broad ligament myomas, or you have severe pelvic adhesion. So during the manipulation of the ureter, don't do sharp dissection, don't do cautery close to the ureter. Try to identify it, and when you do the pressure of the traction during the dissection, the pressure has to be equal, not to be harsh on it. So in order to avoid uterine ureteric injury, it must be localized in almost all the moment throughout the procedures. And I'm gonna show you a video now how in an expert surgeon, they've done complication in the ureter, but they were able to pick it up intraoperatively. To dissect carefully, be prepared for the, by putting a ureteric stent if you have a concern in advance before you start your procedures. The post-operative ureteric injury can present late. And I've seen few cases as a referral in here. And some of really have a problem, like look at the ureteric has been picked up late and there is a big problem here. And the patient has to be taken to the OR for the second time. So this patient presented to the emergency 3 days after the procedures and is being assured and given Tylenol. Down in the road, she came a second time and she'd been asked to go back again. When she came third time, they admitted her and they done ultrasound, not even contrasted CT scan. And they find the surprise that there was significant hydro, referred to my center to deal with the injured ureter. By the time with the system and the queue, when she ended up to my clinic, the DEMSA scan of that kidney was 0. So now the patient, she had her nephrectomy done, and she's preparing for litigation. So listen carefully to the patient litigation, and listen carefully to the patient, involve other teams, and know how to call for help. The third organs to be considered is the bladder trauma, and this is very low injury. And if you are well prepared, you drain your bladder before the procedures, the likelihood to go through this is very low. Again, I've seen these cases, and I was able to correct it intraoperatively, laparoscopically. Mechanical trauma to the bladder is very low, but when you have significant adhesion or endometriosis is always there. Diagnosis is very easy most of the time. You see blood in the urine. The hemorrhagic complication is the other.
2 minutes, Doctor. 2 minutes.
Right. So hemorrhagic complication include hypogastric, external iliac, etc. So I'm not going to go through this, skip them, but I'm going to show you. Need to keep in mind treatment of vascular injury. Don't panic. Communicate with anesthetist. Call for a help. Prepare the blood as required, and move on. Be very low potential to convert to open. I'm gonna now skip all that and bring you to this videos probably, and I would like to share with you here before I finalize. So there are 3 cases here. I'm gonna take you through them. This is a skinny woman underwent umbilical hernia repair, and look at the complication here. So they're doing the dissection. Yeah, look at that. So they pick up here. I would like to look. Now there is huge retroperitoneal hematoma. So what do you think the problem in here? This is a closed technique. So the problem here, the patient went to the great fizzles and with the ferrous needle, and you can see in the next slide and here, the hematoma is being expanding. They resuscitate the patient. They're still insisting to continue laparoscopically, but look at the hematoma, the entrance of the ferrous needle, you see? So that's why you don't appreciate sometimes how disaster it is. So the next step is they call for the help with the immediate laparotomy was done by the vascular surgeon. And they closed the defect, and the patient was transferred to recovery care uneventfully. A second case here, this is another patient. They were doing sigmoid resection, and look at the dissection here. They're going aggressive. The sigmoid is up there, and here they're dissecting this without identifying the structure. See, they're zooming in too much in, no panoramic view, and oops, there you go. This is the ureteric injury here now, and you see how bad is that? But they were able to identify it again intraoperatively. So they slided the guide wire and followed by the stent, and they were able to do laparoscopic repair for this. Urologist was called, and they finished it up laparoscopically. So the third case, probably before I wrap up on this, see that they're doing the primary closure here. So the third case before I wrap up in here is this. The patient, again, they went the direct technique, and they've done big hole in the with the trocars during the trocar insertion, and they done big bowel injury, small bowel injury, and they call again the GI surgeon, and he was able to do primary closure. So the complication is there, and it needs to be kept in mind the potentiality of the happening of the complication, and be ready if it's happened, what to do, and prevention is better than cure. Thank you very much.
Thank you so much, Dr. Maher, for this is very tricky information about laparoscopic surgery. I want to announce, for the sake of the time for the speaker, please, you can go to the chat and answer some question, because maybe you will not have enough time for question and answer. And mashallah, the attendees now more than 3,000. So please, for the more attendees, if they want to attend, the link in the chat, so you can go to YouTube. The webinar also will be in YouTube. Dr. Mohammed Mabrouk attend, alhamdulillah, now, and he will present. Dr. Mohammed Mabrouk is consultant gynecologist and minimal access reproductive surgery, Cambridge endometriosis and endoscopic surgery unit, Cambridge University Hospital. He will talk today about two talks. A first one about modern management of endometriosis, an update, and the second session will be about nerve-sparing surgery for endometriosis. Can robotic surgery help? Dr. Mabrouk, welcome.
Oh, thank you very much. I would like to thank all the organizers, and especially Dr. Samir Sendi, Dr. Hisham Arab, and you, of course, Doctor, for the kind invitation. And I would like also to apologize for the delay. I was in theater and difficult endometriosis case. So yes, it's a little bit, I'm a little bit late. I'm so sorry. So thank you very much for this kind invitation. It's always a pleasure to participate in awareness sessions about to discuss endometriosis management. And for the sake of time, obviously I was supposed to speak about modern management of endometriosis, but for the sake of time, I will try to focus on deep endometriosis surgery, as I think this is what we really need to consider in these days. It's a fantastic opportunity, and I'm very thankful to speak with 3,000 colleagues. This is absolutely amazing. And this is why I'm again thankful to Dr. Samir and His Excellency, Dr. Mohammed bin Abdul Jabbar Al Iman. So in these minutes, I will try to focus on deep endometriosis and why it is a challenge, which teams should manage this, and some new technologies that we use for management of endometriosis, and a quick case study. So first of all, what deep endometriosis is, we know that there are a lot of staging and classification systems for endometriosis, and one of the most utilized ones is the anatomical classification, where you classify endometriosis in ovarian, superficial, peritoneal, and deep endometriosis. So deep endometriosis is when endometriosis penetrates underneath the peritoneum. You can say 5 millimeters, you can say 3 millimeters, you can say whatever you want. But the recent last definition is when it infiltrates underneath the peritoneum without specification of millimeters. And when it is infiltrating the muscularis of the organs, either in the pelvis or elsewhere. It's very preoperatively possibly diagnosed if you have the capability and the centers and the radiology team that can diagnose this. It's related to the type and severity of symptoms. Why am I saying this? Because the best case scenario for endometriosis is this one. A lady that's looking for pregnancy, she does an ultrasound, simple ultrasound, find a cyst, remove the cyst laparoscopically, everything is fantastic. Patient gets pregnant, but this is not the reality. And if this is the reality, endometriosis would have been one of the easiest things to manage. This is not the reality, because this is less than 15% of the patients that you see. The reality is this, and that's what we face every day: endometriosis of the deep endometriosis affecting the bladder, as you can see here, affecting the pelvic nerves, as you can see in this video, affecting the bowel, doing a bowel resection, as you can see, or the ureter, excluding a kidney like this one, where we are doing a laparoscopic excision of endometriosis, parametrectomy, and ureteric reimplantation. So this lady, this is a young lady that was losing her kidney with a MAG3 of something like 20% on the left kidney. And what we did is that we excised the endometriosis, and we did laparoscopic ureteric reimplantation, and no need for hysterectomy, and we will come to this point. So here we have to think endometriosis and we have to consider endometriosis as a challenge. And this is the modern approach for management of deep endometriosis. This is a disease that has clinical impact. It's challenging in its diagnosis, and this is why in very big countries and very advanced, scientifically advanced universities, there is a delay in the diagnosis of endometriosis up to 10 years. And it's a difficult surgery, it's a challenging surgery, multi-organ, so I'm not operating alone at all. If the bowel is involved, we need the collaboration of the bowel surgeon, we need the collaboration of the urologist, cardiothoracic surgeon, and now I'm developing I am the co-director of the Cambridge Endometriosis Center, and we are developing also a neuropelviology unit, which is helping to manage the neurological dysfunctional complaints of these patients. Clinical diagnosis is the most important thing, and if there is a delay of 10 years, 6.7 of these 10 years are in the primary care level. And this is why I'm very thankful that I am speaking in a context like this in Saudi Arabia, and I'm quite sure that this incidence and the prevalence of endometriosis in Saudi Arabia is not little. It's just that obviously it can be a little bit underdiagnosed, or it can be seen definitely and managed by my colleagues there who are very, very good. And I'm sure that they're doing, I've been in Saudi Arabia many times, and I'm sure that with Dr. Hisham Arab, he always, and many others who are doing massive awareness programs in endometriosis. Ultrasound diagnosis is not easy, and my message here is if ultrasound is negative, this doesn't mean the patient doesn't have endometriosis. MRI is very good, but especially and exclusively when it is done by experienced radiologists in endometriosis. Importantly, diagnostic laparoscopy is not the best diagnostic method for endometriosis, even if this is written in all books and all guidelines. But I will show you some examples, but remember that the intraperitoneal cavity is one thing, and what we look for is in the retroperitoneum, which is in another room. So it's important to do a diagnostic laparoscopy to diagnose, but it's all a workup, including radiology and including, above all, clinical diagnosis and examination and understanding the patient's objectives. So the most important thing is to consider this disease, to think endometriosis, especially with a deep entity, to understand the disease itself. More importantly, to understand the patient's objectives. Managing the patient does not depend on the lesion, but depends mainly on the understanding of the patient's objective. We do not do a lesion-oriented approach. What we do for these is a problem-oriented approach. And that's what we are trying also to standardize. I'm proudly an adjunct professor in the Southern University of Denmark, and now we're making a project for standardizing, but it's not very easy to standardize the management because every patient is different. Every patient has its own objectives, and every patient has her own management. We try to make a precise diagnosis and to make the diagnosis before surgery as precise as possible, which helps us to counsel the patient. And our role is not to say to this patient, you have to do. Our role is to give the patient the information and give her the right to help her to make an informed choice. What I'm saying is not new. Deep endometriosis management of intestinal endometriosis has been published since 1946. So this is not something new. And if you come to ask me what's the best management for this patient, my answer is, and that's why I was saying in Denmark, we answered like this. It's not a lesion oriented, it's that you have to put the patient in the center. And this is the way to overcome the contrapositions. You have to take a holistic approach and understand exactly what the patient needs in this exact moment of her life. Does she need fertility? She wants to have a baby. She wants her quality of life. She already completed her family. And this is where comes the question, and I don't think this is a question anymore, and unfortunately I still face colleagues who are asking me this question. Is it better to do this with a cut, laparotomically or laparoscopically? I don't think this is a discussion anymore. It's laparoscopy until otherwise proved. And if this is not my opinion, this is the scientific literature and the guidelines everywhere. The question now is if we do it laparoscopically, it's better, or if we do it robotic assisted, and that will be the topic of my next lecture. And that's what I was saying. Intestinal endometriosis diagnosis is challenging because the endometriosis symptoms are usually misdiagnosed as irritable bowel syndrome. This is my colleague, John Morton, who is operating with me right now. And what we do for endometriosis is that it depends on where the lesion is of bowel endometriosis. If it's superficial like this one, yes, let's say that we counsel the patient if she has symptoms that the treatment could be shaving of this nodule. If it's infiltrating the wall, but it's small, we do a discoid resection. If it's like this one, big and infiltrating and causing stenosis of the lumen, and it's large, more than 3 centimeters, we do segmental bowel resection. Years ago, we used to do these big segments, almost a left hemicolectomy. But in 2012, myself and my team, we published this paper in Human Reproduction where we demonstrated that there is no difference in terms of pain and quality of life and recurrence either of pain or of the lesion itself if you do a big segment from if you do a small one, which is the conservative radicality, the concept of economic radicality, or the less is the better. Remember this picture and why we are saying this. This is not a cartoon. This is the endometriosis, what you can see here, and this is the nerve. So it is a neurotropic disease. Endometriosis goes to attack the nerves, to affect the nerves. And what happens is that this is also another concept, a very important topic in modern management of deep endometriosis is to consider nerve sparing. Why? Because a patient that has 25 or 26 years old who goes to have a surgery for endometriosis and then she has urine retention for the rest of his life, this is a very serious complication. So what we do at the beginning of our surgery, as you can see here, there is a deep nodule, big nodule of the bowel. We don't care. We attack the enemy from the back. We know very well that endometriosis, you don't have to attack the lesion. You go and first you prepare your spaces. As you can see here, we see the nerves. These are the pelvic splanchnic nerves. And we just develop the space to see the hypogastric nerve. And when we secure the autonomic nerves of the pelvis, either sympathetic or parasympathetic, this is where we go to excise the nodule. As you can see here, even when we do bowel resection, which is very frequent in patients that have big affection of big nodules of the bowel or of the bowel, you can see here the right hypogastric nerve, the left hypogastric nerve, and that's what we do, segmental bowel resection, all laparoscopically, but with a super important concept, which is nerve sparing surgery. And I have really invested some years of my life in describing this, and we published this paper with our colleagues from Brazil, from Toronto, and from New York, where we did a cartography to describe where the hypogastric nerves are and where the autonomic nerves are, and to describe a step-by-step approach, and you can find it on JMIG, and I can send it to Dr. Sendy if he wants. Also a video with a stepwise approach of identifying this nerve. It's not scientific fiction, and remember, these nerves are not away from what you do in endometriosis and not. And this is what we go around the world to teach how to do the nerve sparing surgery. Why we as well in 2012, myself and my team and myself, we were the first to describe rectal dysfunctions, objective evaluation of rectal dysfunctions with patients with deep endometriosis, even without surgery. And this was published on Fertility Sterility in 2012. And we found that the patient with deep endometriosis, even before surgery, she has rectal dysfunction. Same concept is with the urinary symptoms. She can have urinary retention and she can have sexual dysfunction. So these are important points to consider if she's going to have surgery. This is very important to discuss. She might have also pelvic dysfunctions after surgery. Urinary endometriosis is not that rare, especially ureteric involvement with endometriosis, as we frequently see. This is not when endometriosis affects the ureter or invades the wall of the ureter. It's when it is creating chronic inflammation and fibrosis around the ureter, and can exclude and can cause significant stenosis and the kidney function loss. So we collaborate with a fantastic team of urologists, and this is how we manage. So intraoperatively, we do a cystoscopy at the beginning. We see very importantly, we have to evaluate where this nodule, as you can see, is from the trigone of the bladder. So if this is a nodule, and as you can see here, this is a dome nodule. This is a nodule of the dome of the bladder away from the trigone. This is an easy surgery. This is not a problem. It's just that we start from one point, we know exactly where the nodule is. And when you arrive to the bladder itself, after preparing all the spaces needed, you check here and then, yes, here you go. This is the bladder nodule. And this patient was very symptomatic, having hematuria every month. And yes, removing endometriosis, reconstructing the bladder, all laparoscopically changed her life. So here, this is a picture that was a patient that was diagnosed as having some adhesions as for previous surgery. But obviously, you can imagine this is the intraperitoneal picture. And if you go in the retroperitoneum, you will see how involved the left ureter is, how dense this parametrium fibrosis is. And that was definitely compressing significantly on the left ureter. And that's why we are very, very keen on understanding ureteric involvement with endometriosis. And this is why in our center, before I leave Bologna in Italy, I was proud to be one of the first to use this technique, which is the endocyanine green. It's an angiography that's used for many, many types of surgeries, but we use it also for vascularization, studying the vascularization with near-infrared cameras to understand if the vascularization of what you're doing is sufficient, yes or not. And also very interestingly, to inject the endocyanine green inside a urethral catheter. And you can see how evident the ureter is. And this would avoid definitely the complication that our colleague has just presented, like holding the sigmoid and cutting the ureter in two. So a very, very important question after this demonstration is where to operate. And here comes an important question, and I don't mean anything. It's for example, here in the UK, there is a very solid system for accreditation of centers of endometriosis. So ours is an accredited center for endometriosis by the National Health System and by the Royal College. If you operate a deep endometriosis in a center which is not an accredited center for endometriosis, and if you're not an accredited surgeon for endometriosis and the patient has a problem, you are in a real trouble. And this is why patients are centralized in endometriosis centers. And here comes the question. I don't say this to say that we are good, but this is a question that has been in the literature. Is it the singer or the song? Is it, if obviously I don't have a lovely voice, no? If I sing a song for, I don't know, Whitney Houston, it will be very, very bad. So this is not a problem of the song, it's a problem of the team, myself and the others. So yes, at the end, the conclusion was that the quality of surgery and the surgery itself are important, but the team operating and the overall preparation of the center itself, as you will see, are very important in achieving safe surgery. And this is why in Europe and in the UK, it's since 27 that there is a system for accreditation of endometriosis centers and building expertise. And this is how endometriosis centers work. They sit here, and in Europe where I used to work and I'm still working, the patient is in the center, as we said, centeredness of the care, holistic approach where endometriosis specialist is one, but he's not the everyone. There's the colorectal surgeon, the urologist, the urogynecologist, the psychologist, the pain therapist, the physiotherapist, fertility specialist, radiologist, obstetrician, and more importantly, an endometriosis nurse specialist who manages to help the patients and be first line of contact with them. This is proudly our center in Cambridge University, and we are developing another one here in the Spire. And I would like to demonstrate quickly this case study. 34 years old patient, gravida 0, 4 years history of infertility, and obviously severe pain symptoms. Laparoscopy and excision of left paratubal cyst done by a colleague who is a fertility specialist, with my full respect, obviously. But this is not the limit of the surgeon. This is the limit of diagnostic laparoscopy as a method. And luckily, this patient had, after this, continued to have pain. And she said, fine, fertility is not an objective now. I would like to manage my pain and quality of life. And she came to our center. We did an MRI for her. And as you can see, there is a nodule here, important, significant nodule of the bowel. But this is not the problem. Laterally here, as you can see, there is a significant big nodule of the left parametrium. And this is where this patient, if you look here to the diagnostic laparoscopy, anyone would say, fine, some adhesions with the bowel, no significant endometriosis, and that's it. But I would like to show you, I will not show you the whole video because it will take some time. But look here, this is the left ureter, as you can see, and this is the nodule of the bowel being shaved out of the bowel. And look here, we are planning for what? For a ureteric reimplantation on the left side. Why? Look, the stent does not pass this severe stenosis of the ureter. It doesn't pass. And the laparoscopy was negative. Can you see how big this ureter is? How dilated it is? And if you see here, it's just that we free the ureter and we cut it. And look how stenotic it was and how back pressure of the urine was there. And then you put the stent, you do the reimplantation, and the problem is solved. And above all, the kidney is saved. So if we want to say something is, yes, our objective is awareness. And this is why I am very delighted to have the chance to speak to you about deep endometriosis. So my advice or my message, if I can give a message, please think endometriosis and consider deep endometriosis. Consider a holistic approach to the patient. Patients do not have pain because menstruation is painful. Patients can have pain because they have severe deep endometriosis. And this is the first lecture. If you, dear Chairman, if you give me the okay, I can go to the second one. Or if you want me to stop for the questions, I'm very happy to stop.
Okay, thank you so much, Dr. Mabrouk. You can proceed to the second one, and the question be after the second one, please.
Oh, thank you very much. This is absolutely fine. So this is the endometriosis awareness. I'm sorry, am I very quick? I don't want to take a lot of your time. So if I'm running quickly, please stop me and say, oh, Mohammed, go slower. Okay.
Yeah, it's okay.
Thank you very much. So again, this is a continuation to what we were saying. And this is a continuation to the concept of nerve-sparing surgery. And I will just try to highlight this concept, and that's it. And also answer the question, because you will see that the literature is not on my side. So nerve-sparing surgery for deep endometriosis. Can robotic surgery help? I have no conflict of interest, and I would like to speak about these topics. Is there a link between deep endometriosis with bladder and rectal dysfunction? And I think I've already partially answered this question. And why nerve-sparing surgery is important for deep endometriosis. And I think I've already answered partially this concept, and how to perform nerve-sparing surgery. And the big question is, can robotic surgery be of help, yes or no? If you look for literature about endometriosis, just last year, you will find, I don't know, 2,000 papers coming, or I'm sorry, these are much more. You will find Cochrane review of the reviews, and you will find about pelvic pain, Chinese therapy, acupuncture, and a lot of things that discussed with endometriosis. Again, it's not new. It's since many years. And if you look here of how this deep endometriosis is, this is not a new thing. But look at the concept of complications. If you do an appendectomy, or if you do a hysterectomy, for example, There is a system, a recognized system for defining the complications, but it's enough to read this paper in 2012 by Jack Donnay and Human Reproduction, and you will find that there are a lot of papers coming after asking for definition and redefinition of complications with endometriosis. Why? Because in this Clavin-Dindo classification of surgical complications, you will find everything up to death. But remember, endometriosis patient is a young patient, 25, 26 years old, who doesn't have, who has a lot of pain and probably is infertile. She has fertility issues. So if you go to remove her endometriosis, and after removing her endometriosis, she cannot weave for the rest of her life. It's not here, it's not classified here. Or if you burn her ovary and she has premature menopause for the rest of her life, this is a complication that's not classified here. And this is why we have to reconsider the complications of endometriosis surgery. And again, this is the same drawing. And we understand that endometriosis is a neurotropic disease. There is an increased density of nerves in the deep endometriosis nodules. We understand that it's associated with nerve infiltration. So these cells go and infiltrate the nerves. And if this helps for, or if this happens for somatic nerves, I'd like to remind you that in the pelvis, there are also autonomic nerves. Autonomic nerves that give sympathetic and parasympathetic innervation to the bladder, to the rectum, and to the sexual functions. A lot of papers, not only mine, who have highlighted the importance of endometriosis in pelvic dysfunctions. And again, this is not my opinion. Look at this paper, 2014, by Marc Possover on fertility sterility, and you will find that the average time, and this is very important, the average time between the surgery and the bladder paralysis or loss of bladder function is 9 years. So you operate on a patient in 2010, and she comes back to you in 2019 with a completely paralyzed bladder, which is associated with, as you have seen, radical resection of endometriosis, segmental bowel resection, or parametrial resection, as we have seen. And this is not because of the song or the singer, it's also because the disease itself affects the nerves. Ours was the biggest in the world in the literature describing parametrial endometriosis and its management in 2018, where we described the management of lateral parametrial endometriosis in 392 patients and the complications that might happen. And if you look at this video, for example, this is a colleague that's actually cutting something, and surgery for endometriosis. He has not identified the nerves as I've shown you, but he's just cutting something. And this thing can simply be the inferior hypogastric plexus, which is the central station of the nerves for the pelvis. And this colleague, for example, is digging a hole trying to remove endometriosis, but this is again the inferior hypogastric plexus. He's just coagulating and coagulating the ureter, and at the same time coagulating the nerves. So it's either direct injury, as you have seen, cutting, or indirect injury, coagulating or causing inflammation. So the nerve sparing surgery is possible, as I have demonstrated to you. We do interfacial surgery. We describe this as a technique, and we continue to move around the world to explain how to do it and to teach how to do it. And the important question, and this is my fight when I moved to the UK, does robotic surgery, can it help, yes or not? So look at this straight stick laparoscopy where we are doing a traditional surgery, where we are, yes, isolating the nerves well, but I'm not sure if this is very, very reproducible. And look at this. Look how layer by layer this surgery is done, and this dissection is done. And this is why when you go to your manager or to the people who pay money, they will look at you and say, okay, my friend, but endometriosis is not cancer, it's a benign disease. And then I got angry and I said, no, it's a benign disease, but it's very important. And I've shown them this video of radical hysterectomy done for cervical cancer and how simple it is compared to this. So deep endometriosis surgery, lateral parametrectomy, is much more difficult than this is what our oncology colleagues say, doing deep endometriosis than doing cancer. But they said, fine, is there an evidence? Evidence in 2017, randomized controlled trial, but the problem is most of these studies consider time, operating time, but they don't consider, for example, pelvic dysfunctions and long-term outcomes of surgery. Another study saying the same, yes, mean operating time is more in robotics. I'm happy to increase the operating time, but you obviously know that with training, the operating time decreases. And if this will help me to improve the long-term outcomes. So there is a fantastic paper that came, and this is what my manager came back to me with, and he said, look, Mohammed, I found this, money for nothing. The role of robotic-assisted surgery in treatment of endometriosis. Mohammed, this is money for nothing. We are not buying the robot. And then I came back to them saying, fine, money for nothing. They said, yes. These are identifying the advantages and the disadvantages. So the advantages of robots are, yes, high degree of freedom in movement, motion scaling, no tremors, ambidextrous capability, and better ergonomics. But the cost of implementation is high, and the inability to move the surgical table, and once the ducking is done, lack of tactile feedback, and the time required to duck and unduck, and the big trocars. And this is where I have been privileged to be one of the first to utilize the Cambridge robot, which is invented and done here in Cambridge where I work. And it actually covers these disadvantages in the sense that the cost effectiveness and the cost per patient is really low. And the bedside units are small, are mobile, where you can freely choose where to put your trocar, and you can operate, as you can see here, very elegantly, and you can see and do surgery, for example, as these colleagues who are doing transabdominal and transanal approach at the same time, using the same system, which is obviously a big advantage. And there is a growing body of evidence about this in the literature. And this is why, if I want, and this is what I went to my manager saying, are you asking me, can robotic surgery help, yes or not? The literature is biased. The literature is speaking about operating time. But if I have a robot that can save me money, because it's almost comparable to the cost of traditional laparoscopy, and can help me improve the long-term and the functional outcomes of the patient, I don't think I need a randomized controlled trial for this. I definitely believe it does, because it's a matter of revolution. No, it's a matter of evolution. So this is how we think that our evolution was. And I don't think we need a randomized controlled trial to prove that this phone is better than this one. Thank you very much for your attention.
Okay, thank you so much, Dr. Mabrouk, for these two very informative lectures. And I think we can open the floor for the question for 5 minutes. We have a question for, we have now with us Dr. Arab, Dr. Maher, and Dr. Mabrouk. The first question was about can endometriosis symptoms continue post-menopausal?
Oh, thank you very much for the question. It's a very interesting one. So there are two myths, two beliefs that endometriosis treated with pregnancy or with menopause. I am delighted to say that this is not the reality. So menopause can reduce the ovarian function, yes. The patient can have less progression of the disease, yes. But the mechanism of pain in menopause, in endometriosis, is not that straightforward. It's not that there is a nodule that's bleeding in her, and if we put her in menopause, or if she goes in menopause, everything improves. It's much more complex. There is inflammation around the nerves, there is invasion of the nerves, there is compression, and there are a lot of mechanisms that cause pain. So yes, if the endometriosis is there, deep endometriosis is there, the patient is in menopause, and she still has pain, please believe her. This is a long-term chronic condition. So yes, it can.
Okay. Okay, second question for Dr. Maher. what are the nursing care pre and post and during endoscopy?
Say that again. What is the
nursing care plan pre, during, and post endoscopy?
Oh, laparoscopy you mean, or endoscopy?
Yes. laparoscopy يعني هما they wrote it as endoscopy, it is laparoscopy.
Yeah. Well, it's very important. In fact, it's a core importance. The team in the OR, they have to prepare the instrument, they prepare the sitting on the backside. If you need to convert to open, they should be fast. There are rules to prepare your cards to ensure that the consumables are required, an instrument per items is available. Their communication by informing them that I'm going to convert, I need this instrument or this sutures to close the defect availability. It is very important. They are the core, in fact. And again, also before when you step to the rooms, they have to know the potential times. They have to know what the position of the patient, what do you need in advance. So preparing the teams so you sail safely compared to they know nothing and shouting in the OR and get stressed with the surprise in the middle of the case, which I don't like. So be prepared, make the team all in the same boat, and everyone understand your language. Particularly when you bring new technology, when you bring new complex cases you are going to do, or you are sharing the case with the other team members. So everyone has to know his or her own rules before you step into the procedure. I think they are core, in fact.
Thank you. For Dr. Mabrouk, what will be the following risk of patient if the patient refuse operation and she's still suffering of pain?
Oh, thank you very much. This is a very lovely question. So there are 2 points that we have to focus on when a patient needs surgery and she refuses, which is absolutely her right. Again, what we do is that we explain to the patient and just help her to make an informed choice. First point is that she is not having a risk of organ damage. Organ damage is basically the ureters and the bowel. So if she has, we have to make sure that there is no stenosis or significant stenosis of the ureter and back pressure on the kidney and subsequent kidney function loss, or she doesn't have bowel stenosis or whatsoever. These are the organ damage. The other risk is malignant transformation. It's not common, but it's possible. And because we are at tertiary care level, we see these patients. They are not inexistent. So there is the endometriosis is not a pre-malignant condition. I have to be very, very clear on this. It does not increase the risk of malignancy. I have to be very clear on this. But sometimes, rarely, endometriosis can be transformed into endometrioid or clear cell carcinoma, which are not good types of cancer. So I have to counsel my patient on this, and I say, fine, if you don't agree to be operated, there is no problem at all. You have pain, we can support you, we can offer you pain management or pain team, and we can offer you a lot of things to manage your pain. We can offer you psychological support, but be with our center, because you might need to have frequent ultrasound of your kidneys. You might need to have some scans to make sure that endometriosis is not becoming cancer.
Okay, Dr. Mabrouk, I want to ask about the Visan role
Yes.
before operation. Do you use it before operation and then operate, or you start operation immediately according to the case?
Thank you very much for the question. So the idea is, should we use medical treatment before surgery? In my center, we have long waiting lists, and even in the private, we have long waiting lists. So the patients, what we do is we give them some medical treatment in the meantime till surgery. So that's our practice, if this is the question. The other question, the other point is what are the guidelines are. So the nice guidelines is for the patients with deep endometriosis, if you can, you give them G and RH analogs. Okay. We give them whatever it is, but you give them some G and RH analogs for 2 or 3 months before surgery. This reduces the neoangiogenesis and the vascularization, and should, in theory, make your life easier, in theory. Visan is a big help, but it's a big problem as well. Why? Because a lot of practices, especially in primary care, they see an ovarian cyst, small ovarian cyst, 2 centimeters, without making a workup to the patient. Say, you know what? I will prescribe you the golden drug, the fantastic drug, the magic one, which is Visanne, but without making sure of what she has and what she doesn't have. The problem with Visanne is that it is good at improving the symptoms, and this is good and bad. Good because it hides the symptoms, but bad because it can hide the pain symptoms and the patient progresses with endometriosis, if that makes sense. So if you want the answer, just to sum up, if you want to give medical treatment, give it before surgery. If you want to give exclusive medical treatment and no surgery, that's fine, but study the patient well. We suggest GnRH analogs because this is the practice here, and these are the NICE guidelines that recommend the use of GnRH analogs.
Okay, thank you so much. For Dr. Arab, there is one question. What are the specific characteristics of pain in endometriosis for patient coming to ER?
Well, thank you for the question. In fact, all the patients actually may come in pain to ER, but working up the diagnosis for endometriosis is really to know exactly the special features of endometriotic pain. Starting a pelvic pain that is really coming periodical, for example, for her dysmenorrhea every month, which really reduce her activity and put her in prison at home for the whole week of her menstruation, and may affect also her other organ functions like bowel, dyschezia, and also maybe during the urination, pain during picturation. So all these features has to be put together in order to, if you want really to point out towards endometriosis. Sometimes the ER doctor is not familiar, and this is a problem with endometriosis. And in this case, we need, through our awareness, that even those doctors need to be, at least the concept or the idea come to their head. If they don't know how to question these patients, particularly regarding endometriosis, then call the gynae physician to take over and work out these cases. Definitely, there will be an requirement for an ultrasound, even for a young girl to have transabdominal, and that will help also guide for. I mean, it's the examination itself can be of help. Unfortunately, sometimes even rectal examination being refused by our girls, but the tenderness that you feel really with the examination, if you can do a vaginal examination, is really typical. That also can point out towards endometriosis. So the many things that we can put together to complete the picture of endometriosis. And I'd like to say hello to Muhammad. How are you? I missed you.
Alhamdulillah, Dr. Hisham. Thank you very much. I really miss you, and I'm very thankful for the invitation. It's absolutely a privilege and a pleasure and an honor for me. Thank you.
Glad to have you, Muhammad.
Thank you, Dr. Hisham. Thank you very much. And my greetings to everyone, to Dr. Samir and Dr. Hassan Abdel Gabbar, to Dr. Maher, and to everyone here, obviously to Dr. Jihan, everyone. Yes, just a moment, please. You're ready. I'm coming. Thank you.
Okay, at the end of our first session, I would like to thank our all great speakers, Dr. Arab, Dr. Maher, Dr. Mabrouk, and I think inshallah Ramadan Mubarak for all of you. Inshallah we'll proceed for the second session. Dr. Cindy.
Yeah, again, thank you very much for all our speakers. We hope that we'll meet soon, inshallah, after COVID-19 in Medina Munawwara to make our conference there, inshallah, because it's our pleasure to be there under care of Dr. Mahmoud Yamani and Dr. Jihan Al-Hazmi. Inshallah. We'll start our second session. We'll start with our senior consultant, Dr. Haj Maroof. He's well-known figure since long time. He's our teacher. He will talk about life care awareness for women 2030. He's a lead consultant, obstetrician and gynecologist and perinatologist. New Care also consultant center in Jeddah and in London, UK. So I'd like to thank him and welcome him to join us. Yes, Dr. Maroof.
Thank you very much, Dr. Samir. I think it is a great organization, and I am privileged to be participating with the panel that I see is one of the very well-versed and very excellent quality staff and people who are participating. And I'm also glad my close and beloved brother and colleague, Dr. Hisham Arab, started his lecture with an endometriotic tune and ended up with a life care, and that was interesting. Now, I'm here to turn all your heads towards another direction. And first of all, I like to say Assalamu alaikum to all of you. And also Ramadan Mubarak. And with this, I will now share my slides. As you all realize, I think the topic is an awareness of women about their health. And it is organized by our own Saudi Obstetrics Society, Saudi Council, as well as the main hospital that is where Dr. Cindy is claiming from, and he's the one who was the main wire, nucleus of this whole meeting. And of course, the very large Ministry of Health. And I see also still people to speak, and I'm given 25 minutes, and I hope I'll keep up to the time. You know, and women's health awareness. Now I changed the title a little bit, and to life care awareness for women in the year. We'll leave her another 8 years to mature ourselves. And in this, I like to take 3 or 4 main conceptual questions. And these questions are, I'm sure all of you are seeing the screen. Is it okay? Samir?
Yes, clear.
Okay, right. I just want to make sure that the sound and the screen are okay. The questions are, number 1, what is life? Where does it exist? Whom does it belong? What happens to it? What is the progress? And etc., etc. The concept is still, it is very clear concept. It is there, but we seem to be concentrating on the focus of our own selves and our body. And that's the play center for all of us. And I'm going to turn you away from that, because what we are dealing with in the hospitals, in the clinics, are people coming with complaints. And this mystery of this life is that it is a form of activity amongst 50 trillion cells, about 500 varieties of them doing different performances, maintaining a unity, which we call life, but each one of them is living, each one of them is functioning, and in fact, optimal functionality of each of those cells, or at least the majority of them, is required. Otherwise, we start becoming cuckoo. If the motor system of our locomotor system of our muscles, of forbearance of our weight goes, we are finished. We can't walk, we can't drive, we can't move around. So with this principle, life is a mystery, and it is a very important thing for us to understand this. So I'll start with this awareness of life, its presence, how to conduct it, how to manage it. All this, we need to understand it. Not only that, we need to also present this to our clients. Now, why do I call ourselves clients? Because when you want to give life care, you address the whole wide world. You don't address the people who are coming with pain and endometriosis. You don't come to the point of people who have menopause or obesity or all of those problems. You're talking to everyone. Everyone, our guidance should be that every one of those trillions of cells that I mentioned should be functioning optimally. So as to they live up to the full time they are supposed to live, which is between 7 and 10 years each. Then they replace themselves with another cell by a processing which is monitored by a system called a telomere system. And each time they reproduce, one of those telomere system goes away, and we have 22 of them. And now that we are beginning to learn to reverse aging, we are beginning to grow some telomeres as well. This is the advances that are going on in the anti-aging area. Now, I must keep my time because this is a very vast subject, but anyway, I'm going to quickly jump into the hat of awareness in a minute or two. Why did I got to this screen? Oh, I did. Okay, sorry about that. Are we back in the screen?
Yes.
Okay, thank you. The owner and creator of life, as Muslims we know it is Allah. Every religion, they have acceptance, and I have a belief, all of them believe in God. Whether it's Hindu or Buddhist or Christian, they all believe in God. They believe in Allah. And so the life doesn't belong to any one of us. Then what is our position in life? We are the keepers and managers of life. So we have to contribute towards keeping and managing these cells or community of cells that is living in us, doing their perfect work so perfectly, keeping us alive, active, and productive. Don't forget, around us, if you turn around and look behind or behind these people, there are other forms of life. Life which is the tree, the plants. Turn around behind, and if you look a little further, you will see the animals and the birds flying over. All of them are lives. So we are responsible for that. In addition, very strangely, another 50 to 100 trillion of lives live within us. They are the lower echelon lives, which are microbes, which live symbiotically with us. They are called the microbiome, an area which has just expanded all of a sudden in the last few decades into a massive area. And they do help us in maintaining immunity, in providing support in our lives in various aspects, mainly the immunity. And they live along happily along with us. And if we do damage them, as we will come to that a little later when I talk about the vaginal ecosystem, you will realize that they all play their role. They are all kept there with precision. And I must say precision very accurately. I'm sorry about that. Just a reminder, okay? Now, where is life kept? Bill Bryson, any of you have had a chance to read this book. Of course, I bought it at half price as you see it. And I have also bought the electronic one. And it says it is the guide for the occupants, this book. So the body itself is having the whole set of life activities that is going on, and the life is in individual cells, and the body, this book describes the exact numbers of them, the amount of chemicals they produce, the amount of chemicals they get rid of. It's a beautiful treatise if you would like to read it. So this body, again, we use it to take this life that has been given to us, keep it nicely, and use it and do what we want, achieve the happiness that you want to get, achieve the calmness that you need to get, achieve the objectives that you need to achieve, and go on with our lives. All of a sudden, things do change because of misuse, abuse, and interventions and invasions. As you know, the invasions are from the bacterial world, sometimes misuse, sometimes overexposure to the sun, for example. All those can change your body's ability to function optimally. The main word to remember is optimal. Now, people have used the name Life Care and used it all over the place. They say Life Care Hospital. Oh my God. What life care is that? You're not taking care of life, you're getting rid of the disease. That's where the hospital is. All the very advanced the operations and that we are doing are getting rid of illnesses, refurbishing the life that was already torn up, and we bring it back. Sometimes we tear it up ourselves, as you have seen in some of the videos that were shown. But it is available to everyone. Uneducated and the poor need it most. But they are the least affected by it or able to benefit by it, unfortunately. Women, I believe, play a very, God has created man and a woman to be two halves of a complete cycle of life. They are two individuals, but they form a set of life which reproduces more life. If the man and woman don't get together, there won't be any more lives. Today, in the name of equality, poor world, they are claiming men and men can marry and live together happily thereafter. Oh no. And they also say women and women can live together happily thereafter. This is a psychological state of happiness. And I mentioned the psychological word before the happiness because it is not the normal happiness everyone has. Okay, so some people may disagree with this. I don't agree with that particular concept of having equality by having men and men married to each other. Okay, one emulates a woman, other emulates the husband, or and they carry on in their life. Don't forget, around us, as I told you, the environment, which is other than the living things, we have the mountains, the earth, the river, and they all have certain functions in our lives. They form the so-called ecosystem that is created to us. the sky, samawat, and this sky protects us. In fact, it collects the oxygen into layers of ozone and protects the ultraviolet ray of the sun, which can kill us in a few seconds. We destroy it, continuously destroy it by cutting down trees and producing pollutants from the so-called carbon monoxide pollution that come from the cars and the planes, and all this is happening. The whole world is disintegrating. So we need to educate everyone. We call this empowerment. It's not education. They have the knowledge, only to remind them about this. Okay? And certainly, if you go and Google life care, you will get thousands of people offering life care to the old man who is Googling. Unfortunately, that doesn't happen. Life care begins at the time when we were just the fused, the sperm and the ovum that has come together as an embryo at the one cell stage. That's what we were. That's what we were formed as the first form of life. Now I'm going to move a little faster, and life care itself, therefore, it's a dynamic concept that needs to identify, developing, utilizing contemporary concepts and modern facilities, including digital information technology and communication. And it is, remember, as I told you, it's an optimum care of those individual selves. For fitness, you maintain fitness, you maintain youth, you maintain health. Of course, we, being gynecologists or obstetricians or in the area of women's health, we want to maintain this for women, because they are this combination I told you, they become the majority. They have different type of mentality than the man. They have different form of body than the man. So there is a big difference between the two. Although unequal in terms of the body and the strength, mind and the capabilities, they are individuals, have their own rights to live and live well. And they can make themselves happy in a different way, and the best way is to live as Allah wanted it. So now we are going through this wellness revolution, and this wellness revolution is going to take over. I put the target of 2030 as a wellness revolution for awareness. But very soon, in the next decade or so, the health system, the Koha system, health system, okay, Saha, Koha, the coughing system will disappear, and we will have to look after our lives. So start planning your lives today, and I'm going to move through this and into the awareness. As we are in the COVID era, we have been humiliated by the 45 nanometer coronavirus to be kept and locked up in our houses for hours together. And we need to understand vaccination that was discovered long time ago has some form of help. Prevention, they say, is better and better than the cure, and that is the first thing. Then we have to organize ourselves, and our life care must be scheduled in the way we to live. If we were properly organized in our life care, there wouldn't have been a pandemic. This is not a theory, this is the reality. The whole pandemic spread through the world because of the leaders, starting with Trump, of course, I'm sorry. But it is completely destroyed by leadership, which we vote and we elect them. They are incapable of doing such a global activity as to stop a pandemic. Today, everybody has lost somebody of their own in this pandemic. Millions of lives have gone overnight. Okay, this is a warning, and this is why we have to remember that we have to maintain our ecosystem. So awareness of the ecosystem is absolutely important. Now I move through the next two things. This is another elephant that my brother Hisham mentioned.
It's 16 hours.
This fibroids is another thing which will usually not seen. Almost 80% of women will get fibroids by the age of 50. 25% of them will die with their fibroids in their uteruses, and that is not an uncommon thing. Okay, but its symptoms must forewarn that you can look for it. The awareness begins with if somebody starts bleeding excessively or painful. Now, strangely, these are the symptoms that also comes with advanced endometriosis. So we need to have systems which will distinguish between these two and establish appropriate lifestyle. I'm very glad Hisham is the inventor of these 4 very infamous and very, very wonderful system called the life care system for endometriosis. And we have started taking back what our leaders in the past have had shown that they were leaders in medicine. There is another leader who is coming back and beginning to start telling the world what is new about life and disease. Uterine fibroids, the risk factors must be understood by women. So if they are aware of it, we empower them with this, they will come back to you the slightest thing, and then you rule out, no harm done, it is done. So that's one. The other common thing, they must need to understand what is normal vaginal discharge, and they will be aware of what is abnormal. And they also should understand there is a vaginal ecosystem maintained by a bacteria called lactobacillus, which maintains the pH of the vagina, gradiently of course, between 3.8 and 4.2, which promotes the growth of lactobacilli but inhibits the growth of the foreign bacteria that can invade our body. The same thing happens with the biomes that live down the intestines. They keep them away and keep all their invading organisms, eat them up or finish them off. Now it's very important at certain times of their lives, they must be very much be careful, especially during menstruation and sexual activity. And I can very well clearly remember, I had one of my colleagues who was an administrative staff, whose wife had a miscarriage. We did a D&C. He came back that night with the wife having severe pain after having sexual intercourse with her.
2 minutes left, Dr. Maruf.
It is a strange thing indeed that this awareness must be present in the wives as well as the husbands who are dealing with their wives. Unnecessary antibiotic therapy can promote vaginal infections, unfortunately, and obstetrical and gynecological procedures, even though it's done under very sterile, within inverted commas, methods, okay, and postpartum hemorrhage also can cause that. Of course, if you destroy your ecosystem, the vulva and vagina suffers, okay? And there is a vicious circle that's going on, which is hygiene. They call it personal hygiene. And if we are not aware, now we have been introduced to washing our hands as soon as we come back, after we're going to the shop, after going somewhere, touching the door, touching the bell, touching everything, because we'll carry coronavirus. 45 nanometer coronavirus has made us taught that lesson to be careful in avoiding this type of things. And many people are selling beautiful soaps, creams, tissue paper, this, that, fantastic, to clean up all the bacteria in the vagina, and they end up with more infections. They must be aware that soap is an irritant and cannot be used. And they should have appropriate solutions which are marketed and approved by the proper health authorities. Another epidemic, or this is a pandemic, in fact, is obesity. We have uncontrolled eating. The WHO calls it an emerging menace. Okay? More than 1 billion people out of the almost 8 billion people are overweight. And obesity is not sacred to one country like the United States. Of course, it is it is the winner of the race, but the rest of the countries too. Even Korea has obesity, although it is only 3%. Obese woman is thrice as likely to be infertile, and therefore it is another problem in our plate. And they must be aware. Women, poor women, they will suffer, and they pull their hair out asking for help. What shall I do? Detox, fat-free diet, this, that, vegan, weight loss. No. Here is where life care is necessary. The mystery menace that we talked a little while ago, aptly and promptly provided by two experts in that area, Dr. Mabrouk, who is one of the fantastic surgeon that I have seen, laparoscopic surgeon in the world I have seen. He's taking back the leadership of our group in the world. I'm very proud of him. And so am I, my beloved colleague, who is also close as my brother. He is a leader in education and positivity in managing and teaching people. If you find any symposium in Saudi Arabia without Hisham Arab, that is not a proper symposium. And that much of information we get from him, and he studies them. He's very thorough. If you look at the the information he presents, is very, very scientific indeed. Sorry, something is happening. Okay. Now this endometriosis is a funny system. It is silent to severe, extensive to excruciating. Somebody can have a massive endometriosis and nothing will happen. No pain even, sometimes. And to the other end, mild nodules, small nodules, and they have severe excruciating pain. And it can spread to anything from A to A, A to C, A to Y, I live to Ya, anything. Anywhere you can find it. And it will be an endometriosis because it spreads by the bloodstream. The other one is related to the very famous relationship with man and woman, sexual. And these infections are again brought about by complete ignorance of the so-called sexuality and its importance. Very much given. Sorry to say, I have to say, Islamic guidance is so much that it gives you so much of cleanliness into the whole life of ours. And a simple thing like herpes virus spreads like mad, and it is one of the most common sexually transmitted diseases in the world.
Sorry, Dr. Ma'ruf, time's up.
Yes?
Time's up already. So can you summarize this?
I cannot hear you properly. Anyway, can you hear me well?
Yeah, but time's up already.
Okay, right. I'm just a few more slides. It's okay?
I try to finish it in 1 minute, please.
Yes, okay. Again, I'm just going through this. The other important thing is cancer prevalence, and we have a very obnoxious cancers like the breast cancer and the ovarian cancer, which is hidden until it becomes very, very advanced state, and colon cancer and colorectal cancer, but endometrial cancer as well. But women has to be told to be aware of this. And these are the gynecological cancer that are most common amongst the women. And breast, of course, comes at any age and kills the most young women who die of cancer in the world, die of breast cancer. Then comes the aging. Now we see people, and 2 weeks ago, I saw a 100-year-old lady running a race and winning it in Australia, Gold Coast. So people living up to 90s and 100s. The 100 of today was the 60 of those days. When people reach 60, they said old. Today, you have to reach 100 to be certain you are old. And we are going to live up to 140. Scientifically, we are going to live up to, we can possibly live up to 154 years. I won't tell how the calculation comes because we don't have time, okay? And so the menopause is another important situation. If you call for life care, as I told you, the first thing they will say is it's a care given to the old people when they are dying or when they are nearly dying, they are unable to look after themselves. No. Life care begins at when you are a single cell and a stem cell. So we look into the legacy of healthcare or future life care, and I call it Hayati, my life. I have to look after. I have taken the responsibility. Who gave me this life to keep in my body and pass it back to him. And that is our duty. Technology is moving fast. If you all have seen me on the picture, you will see I'm wearing one of these. This is producing negative ions, and which is simulating. If you wear this, you will be as if you're in the sea beach or near a waterfall, relaxing on a holiday, but you're working. Stress breaking. All the 72 psychotic drugs can be got rid of. I'm not advertising this equipment, but the fact is it is producing ions which are present in nature. You pay for holiday and go to the beaches, go to the mountains to get these ions. Now we are producing it at our home using this equipment. I have many scientific advances like this. Of course, this is not the appropriate place and time, but I just wanted to mention technology is advancing exponentially. And exponential means, I want to tell you the difference between 30 exponential steps of 1 meter, 30 linear steps take you 30 meters. Exponential steps will take you to 800 million meters, which is about 26 times around the world.
Can you summarize, please, Dr. Maroof, because time's up long time ago.
Thank you very much. I'm sorry about that.
Sorry for
I finished. This is my last.
Okay. So I'd like to thank Dr. Maroof for his interesting lecture, and I'd like to thank him for his talk. At the same time, I encourage all speakers to answer the questions in question and answer. And please, whoever coming to join us, please, you go through YouTube and you can join us. Now we have more numbers coming from the YouTube through our participant. Our next speaker, the first speaker, which I talked to her from Medina Munawwara, our colleague, Dr. Rihab Al-Ruwaithi. It's good that we have actually from our generation and from Rihab generation, young generation. It's nice to hear from her. She will talk about menopause. She's a senior registrar, obstetrician and gynecologist from Al-Medina Al-Munawwara Maternity Hospital, and it reflects that also number of speakers from young generation are joining us because also Rihab is joining us. Welcome, Dr. Rihab.
Thank you, Dr. Samir Sindi. Alhamdulillahi Rabbil Alameen, wassalatu wassalam ala ashraf al-khalq al-mursaleen, سيدنا محمد بن عبد الله وعلى آله وصحبه وسلم تسليما كثيرا. Thank you so much, Dr. Samir Sindhi, for this nice invitation. Thank you, Dr. Jihan Al-Hazmi, for this nice invitation also. I am happy to be one of the speakers in this great webinar. I would like to talk about the menopause. Menopause is a physiological or iatrogenic cessation of menses, amenorrhea due to decreased ovarian function. Manifestations include hot flashes, night sweats, sleep disturbance, and genitourinary syndrome of menopause. Symptoms and signs due to estrogen deficiency, such as vulvovaginal atrophy. Diagnosis mainly of menopause is clinical, absence of menses for 1 year. Manifestation may be treated with lifestyle modifications, complementary and alternative medicine, or by hormonal therapy. Perimenopausal period refer to several years. Duration varies greatly between woman to woman before and after the last menses. Before and 1 year after the last menses. Typically the most symptomatic phase because the hormones are fluctuating greatly in this period. Menopausal transition refer to years and perimenopause that lead up to that lead up to the last menses, characterized by changes in menstrual pattern and divided into early and later stages. The menopausal transition lasts 4 to 8 years. It lasts longer in a woman who's smoke and in a woman were younger at onset of menopausal transition. Postmenopausal period refer to time after the last menstrual period and also divided into early and later stages. What are the symptoms and signs related to the menopause? The first is vasomotor symptoms, including hot flashes and night sweats, due to vasomotor instability affecting 75 to 85% of the women and usually begun before menses stop. Women feel warm or hot and may perspire. Sometimes profusely core temperature increases. The skin, especially of the face, head and neck, may become red and warm. The episodic flashes and may last from 30 seconds to 5 minutes and may be followed by chills. Flashes may manifest during the night as night sweats. The mechanism of hot flashes is unknown, but is thought as a result of changes in thermoregulatory center located in the hypothalamus. The hot flashes include sensation of intense heat, sweating, and increased heart rate. The experience, duration, and intensity of hot flashes, as we said, it varies from woman to woman. The other symptoms and signs of menopause, vaginal symptoms, including dryness, dyspareunia, and occasionally irritation and itching as estrogen production decreases. Vulvar and vaginal mucosa become thinner, drier, and more friable, and less elastic, and vaginal rugae are lost. The other symptoms and signs related to genitourinary syndrome of menopause, this including vulvovaginal atrophy, urinary urgency, dysuria, frequent urinary tract infections. Vaginal dryness because of decreased normal secretions from the cervical secretions that moisten the vaginal wall. Also, absence or lack of the secretions secreting from the Bartholin glands. This can affecting the sexual intercourse greatly. The other is loss of libido. During menopause, there is decrease in production of sex hormones, so it can result in loss of libido. The other symptoms and signs related to menopause, neuropsychiatric symptoms, and there is variety of changes with like a poor concentration, memory loss, depressive symptoms, or anxiety may transiently accompany the menopause. Recurrent night sweats can contribute to insomnia, fatigue, irritability, and poor concentration by disturbing sleep. Sleep problems also caused by the disturbing hormonal level in postmenopausal period. The other symptoms and signs related to cardiovascular after menopause, the level of low-density lipoprotein cholesterol increased in the woman. So the level of HDL, the level of high-density lipoprotein cholesterol remain, but the same as before the menopause. The change of LDL level may partially explain why atherosclerosis and thus coronary artery disease become more common among the women after menopause. However, whether these changes result from aging or from decreased estrogen level from the menopause is unclear. Until menopause, the high estrogen level may protect against coronary artery disease. Other symptoms and signs related to musculoskeletal, up to 20% of bone density loss occur during the first 5 years after menopause. After this period, rapid bone loss and age-related rate of bone loss in the woman is similar to that in the men. There is significant weight gain and slow metabolism in postmenopausal ladies. So this related to decreased circulating estrogen level in the circulation, age-related loss of the muscle tissue, and lifestyle factors related to diet and lack of exercise in postmenopausal ladies, thinning of the hair and dry skin. The diagnosis, as we mentioned before, it's mainly clinical. These ladies, they need clinical evaluation. Rarely we need to go for FSH level. Perimenopause is likely if the woman in appropriate age range and has some of the symptoms and signs of perimenopause. However, pregnancy should be considered or to be ruled out. Menopause is confirmed when the woman has no menses for 12 months. FSH level may be measured, but this test is rarely necessary except perhaps in a woman who have hysterectomy and in a woman who are younger than the usual age of menopause. Consistently elevated level confirm menopause. The following postmenopausal women should be screened for osteoporosis. Those who have high risk for fracture, like a patient with family history of osteoporosis, and those who have a history of eating disorders, low body mass index, chronic corticosteroid use, gastric bypass surgery, Crohn's disease, a malabsorption syndrome, or a prior fragility fracture. All women above 65 years mandatory to be screened for osteoporosis. What are the modalities of treatment of menopausal symptoms? We have lifestyle modifications, complementary and alternative medicine, hormonal therapy, neuroactive drugs. Treatment of menopause is symptomatic. For example, to relieve hot flashes and symptoms due to vulvovaginal atrophy. Treatment may also include prevention of bone loss and osteoporosis. First, we will start by hormonal therapy. We can give the postmenopausal lady estrogen alone, or we can give her estrogen and progesterone in combination, or we can give her progesterone only. This is the most effective treatment for menopausal symptoms, but we have to put in our mind there is list of contraindications. We have to discuss it clearly with our patients. Contraindication for oral and transdermal estrogen-based therapies include known, suspected, or a history of breast cancer, known or suspected history of other estrogen-based cancer like uterine cancer, women who have had a hysterectomy and have no remaining evidence of the disease are still candidate for HRT. Active deep venous thrombosis or a history of DVT or pulmonary embolism, history of blood clotting disorders, the most common being factor V leading mutation carriers, active or a history of arterial thrombotic disease such as myocardial infarction or a stroke, chronic liver disease or dysfunction. These contraindications, as we mentioned, only applied for the oral and transdermal estrogen-based therapy, but not applied to transvaginal-based estrogen therapy, as the serum concentration of estrogen from this route is extremely low. The choice of hormonal therapy for the women who have had a hysterectomy, estrogen used alone, oral transdermal, patch, lotion, spray or gel, or vaginal form may be used. Treatment should start with the lowest dose. The dose is increased every 2 to 4 weeks as needed. Doses vary by preparation. Low doses include 0.3 mg orally, once a day conjugated equine or synthetic estrogen, 0.5 mg orally once a day oral estradiol, or 0.025 to 0.375 mg a day released by a patch applied to the skin once or twice a week estradiol patch. If the woman who have uterus here should be given a progesterone in addition to estrogen, because the unopposed estrogen increase the risk of endometrial cancer. The progesterone is taken with estrogen continuously in daily basis or sequentially 12 to 14 consecutive days of every 4 weeks. The dose, medroxyprogesterone acetate, 2.5 mg for a daily use and 5 mg for sequential use. Meconazide progesterone, a natural rather than synthetic progesterone, 100 mg for a daily use and 200 mg for sequential use. Bleeding due to progesterone withdrawal is less likely with a continuous therapy, although irregular bleeding can occur during the first 6 months of therapy. When the only symptoms are vaginal in a postmenopausal lady, here we can use low-dose vaginal estrogen therapy is preferred. Topical form like creams, vaginal tablets, suppository or rings may be more effective for vaginal symptoms than oral forms. Vaginal tablets, suppositories or ring that contain estradiol in low doses like 10 mcg for a tablet, 7.5 mcg for rings, 4 mcg and 10 mcg for vaginal suppository deliver less estrogen to systemic circulation. Monitoring. Hormonal level of estradiol and progesterone not traditionally measured for monitoring purpose. Instead, the relief of menopausal symptoms and absence of adverse effects signify an adequate medical response. There is a newer therapy for dyspareunia, including selective estrogen receptor modulators like oral ospemifene or intravaginal DHEA. But the hormonal treatment, we have also list of risk and adverse effect. Risk of estrogen therapy or combined estrogen and progesterone therapy, including endometrial cancer, mainly if the woman have a uterus, take estrogen without progesterone. Risk for breast cancer, DVT, and pulmonary embolism. Risk of stroke, coronary artery disease, dementia, gallbladder disease. The other modality of treatment, lifestyle modification for hot flashes. The following may help: avoiding triggers like spicy food, bright light, comforters, predictable emotional reactions. Cooling the environment, lowering the thermostat, and using extra fans. Wearing clothing in layers can be removed as needed may help. Exercise and weight loss greatly help to improve quality of life. Over-the-counter vaginal lubricant can help vaginal dryness, and regular sexual intercourse or other vaginal stimulation help to preserve vaginal function. But here, okay, we'll go for next slide. For the complementary and alternative medicine, we have also, this is another modality of treatment, the some of the postmenopausal ladies, they are preferring to use herbal medication rather than using the hormonal replacement therapy. Examples of this alternative medicine, like black cohosh, may be helpful in a short term, in less than 6-month treatment of women with vasomotor symptoms. St. John's wort may be helpful in a short term, less than 2 years or equal, for mild and moderate depression women. This St. Johnson worts, it's as I mentioned in the books, it's عشبة القديس يوحنا. They mainly there is a variety of indications for this type of medication, but mainly they are using this for relieving depressive symptoms. Soy and isoflavones intake over the prolonged period may improve lipoprotein profile and protect against osteoporosis. Soy and isoflavones may be helpful in a short term, less than or equal to 2 years treatment of vasomotor symptoms, giving the possibility that these components may interact with estrogen. These agents should not be considered free from potential harm in a woman with estrogen-dependent cancers. This is very important point. When we are discussing this with our patients, we have to put this in their mind. There is also risk from taking these kind of a medication. Acupuncture also have had a mixed results. So here all the patient should be asked about their previous use of herbal medication if they use it before, and dietary supplement if they are using, and all these must be documented in the patient file. So the natural way of treatment, it's not assurance of safety and the efficacy. There is maybe potential dangerous interactions could be happen between giving medication and herbal medications if she's currently using. Neuroactive drugs in well-designed randomized controlled trial, selective serotonin reuptake inhibitor, SSRIs, or serotonin norepinephrine reuptake inhibitor, SNRIs, and gabapentin have shown to be moderately effective for reducing the hot flashes. A low dose 7.5 mg once a day of paroxetine, a selective serotonin reuptake inhibitor, the only approved non-hormonal therapy used specifically for hot flashes. However, all of these drugs are less effective than hormonal therapy. At the end, our key points: in Kingdom of Saudi Arabia, the menopause occur at average age of 51 to 52. Symptoms of menopause tend to be maximal during a few years before and year after the menopause, during the perimenopausal period, except for symptomatic vulvovaginal atrophy, which may be worsened over the time. Up to 20% of bone density loss occur during the first 5 years after menopause, followed by age-related rate of bone loss similar to that in the men. Consider menopause confirmed if the woman who is in appropriate age or is not pregnant and not had a menses for 12 months. Thank you so much.
Thank you very much, Dr. Rihab, for your interesting lecture. I'll encourage all speakers to answer the questions, please, and answer because of shortage of time. I would like to introduce Dr. Shaza Maqsood. She is a senior consultant obstetrician and gynecologist. She is actually trained in the United Kingdom and Ireland. Currently, she's working in Dr. Sulaiman Al Habib Al Rayyan, Riyadh. She will give us a nice, attractive subject, which is the Mirena intrauterine system contraception and hemorrhagic menstrual bleeding hand in hand. Welcome, Dr. Shadia.
Thank you very much. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyidina Muhammadin wa alihi ajma'in. Thank you so very much, Dr. Samir Sandhi, for arranging such a fantastic OB-GYN webinar with more than 3,000 attendees. I would like to extend my gratitude to His Excellency Mr. Mahmoud Al-Yamani also, and to all the esteemed panelists who I am very, very glad to share the platform with. Today we are going to talk about Mirena coil. We are going to talk about the levonorgestrel intrauterine system. Now, I'm sure all the gynecologists on the panel, as well as the 3,000 attendees, most of you are familiar with the contraceptive efficacy of the levonorgestrel intrauterine system, which we call long-acting reversible contraceptive, or the LARCs. So the next few slides are going to discuss with you about the LARCs, because somewhere along the line, we think that, because of the irregular nature of bleeding associated with the long-acting reversible contraceptives, Mirena inclusive, sometimes, we lack in some sort of counseling specialties, counseling abilities, that we are not able to promote the benefits of this type of contraception and this type of treatment modality for hemorrhagic ovarian bleeding, or heavy ovarian bleed, or heavy menstrual bleeding, or menorrhagia, which we commonly call. So my talk in the next 20 minutes, I'll try to incorporate all these things, and also some extra qualities which the levonorgestrel system carries to treat some other things, or to be partner in treatment with some other medical problems with women's health also. So without much further ado, let's talk about the major impact on a woman's quality of life. When menorrhagia occurs, when heavy hemorrhage occurs, it has a great impact. It impacts us negatively with our relationship to our partners. It decreases our work productivity. For those of you who work in the ER know that, on a monthly basis, how many sick leaves we may need to issue in terms of menorrhagia and dysmenorrhea, with young girls coming with heavy menstrual bleeding or disorder. Of course, it leads to iron deficiency anemia if not treated long term. It causes a lot of discomfort of having to change frequent pads or tampons, and overall decreased quality of life, causing anxiety. So most of the time when a woman comes to you in the clinic, they are manifesting all these problems, and you have to be a good listener and with a holistic approach, as Dr. Marouf's philosophical and holistic talk embedded overall, holistic care for women's health. I will also talk on certain different levels, and we will put in some science in it as well. So the basic idea when menorrhagia occurs, when heavy menstrual bleeding occurs, is to stop the heavy period. Isn't that right? So what we do, what are the options available once you have diagnosed, okay, somebody is having menorrhagia and heavy menstrual periods? So we have the drug therapy. We have the levonorgestrel intrauterine system, which is called Mirena, and it's available in our country. We can go for more surgical options, which is endometrial ablation or a hysterectomy. But hey, wait. Why are we talking about Mirena today? What is the reason why we are emphasizing on Mirena? So let's talk about a bit of a history. This levonorgestrel intrauterine system dates back from ages and ages. In 1990s in Finland, this was invented. And from the concept of contraception, the spectrum eventually grew. And then in 2009, the US FDA approved this for heavy menstrual bleeding also. And it is also approved for treatment as a progestogen arm of estrogen therapy with hormone replacement therapy as well. So wow, there are so many things that you can do with the levonorgestrel intrauterine system that we need to talk about it, we need to reiterate it, and we need to talk about why we are thinking about it, talking about it, and fitting in lesser Mirenas than anything. So this intrauterine system, it has progestin in it. It is a T-shaped polyethylene frame, and it contains 52 milligram of levonorgestrel, but ideally on a daily basis, it releases about 20 microgram levonorgestrel daily. So local is logical, local mode of action. It prevents endometrial proliferation, and hence we are talking about it being certified to work for hemorrhagic uterine bleeding as well. It also inhibits sperm motility. It thickens the cervical mucus. Hence, it is a very good contraceptive option as well. And in the UK in particular, when somebody comes to ask for a tubal ligation, a laparoscopic sterilization procedure, we always counsel them also for the Mirena, because it is sort of, you know, is a versus situation where a 1 in 200 of a procedure of a lap study can fail, and Mirena has the same efficacy, albeit a bit better. So let's face the challenges with long-acting reversible contraceptives, shall we? When somebody comes to you for talking about contraception or talking about heavy hemorrhage bleeding, what happens in general is that we are counseling them. We need to be motivated ourselves. Are we motivated enough to tell you that this product that we are going to offer you is going to be a good option for you? So we need to be motivated ourselves. What about counseling? How good are we in counseling? How good are we in actually listening to when somebody is speaking to us? So that's the most important thing. Then comes the insertion of the coil. So if the coil is inserted properly, it rarely ever gets displaced. And we learn that with our experience. What about, but you'll say, hang on, Shazia, what about the hormonal side effect, the intractable bleeding? Ramadan is round the corner. If I fit in a Mirena, the woman will be sitting in my clinic every week, you know, begging me to remove it or give me some solution for that kind of intractable bleeding that she's not able to pray and fast, etc. So I will question you back. What did you talk in counseling, and how about post-insertion follow-up and post-insertion advice and about the irregular bleeding? So when somebody comes to us with a heavy menstrual bleeding, as the previous speakers have been clearly talking about in menopause and in holistic approach, that she would have done mostly, if not all of them, before coming to us. She may be using ice baths, she may be using aromatherapy, infusion teas, healing with herbs, considering acupuncture. And believe you me, on the iherbwebsite.com, if you type menorrhagia, there is about 400 products available over the counter that women can buy. So nowadays, it's not uncommon if somebody comes to the clinic and you ask them, okay, what medications have you used or you're using? She'll pull out from her purse a list of medications or a list of bottles, or on her mobile, she will show you a list of medications that she is using. And we are not surprised with that. It's a consumer-oriented medicine field now. So the food for thought is that over 60% of women that we diagnose with hemorrhagic menstrual bleeding end up having a hysterectomy within 5 to 8 years of diagnosis. Somebody comes to you, they say, oh no, we are not getting full benefit of the medications we took. My aunt had a hysterectomy. I was told by my mother that, you know, have a hysterectomy. My mother had a hysterectomy. Or I went to Fala doctor and she advised me hysterectomy, so I'm coming to you for a second opinion. So about 1/3 of hysterectomies, did you know that about 1/3 of hysterectomies, when the histopathology comes back, we are actually removing anatomically normal uterus. So that enough should hit us that, you know, could there be a role for us to be motivated? If we are motivated, could our words change their world? Because remember, what you say stays with the patient, and most of the patient will tell you that the way you counseled me, about 50% of my disease is already gone. So that is the art of good listening, and that is the skill of being motivated in order to counsel somebody. Now, so here's the science now. There are so many countries with international guidelines which are propagating already for levonorgestrel intrauterine system as their first-line treatment in heavy menstrual bleeding or hemorrhagic menstrual bleeding. America, Canada, UK, Malaysia, France, New Zealand, Finland. So everybody, and here are the guidelines in review. If you can see that the levonorgestrel only pill, levonorgestrel only system, first line mentioned in all these guidelines. So what about the efficacy of Mirena in idiopathic menorrhagia? Now, when we say idiopathic menorrhagia, we means that there was no polyp found, there was no fibroids found, we also ruled out a hyperplasia, etc. So what's the efficacy of that? Say for instance, if somebody was coming to you with a daily bleed of about 120 mils with bad anemia, low ferritin, look at what happens. Pre-insertion, this was the blood loss. And then within 6 months, it went down to considerable 78%, to about 2 years time to about 98%. And then it just flung back a little bit to 85%. What does this mean in words when you're telling the patient? That 8 out of 10 ladies in your situation whom I will fit in a levonorgestrel system will have a considerable reduction in the amount of bleeding that you're having right now. So that is the most important thing that you need to take on board. There's a 97% reduction in menstrual blood loss over 1 year, and there have been so many randomized control trial addressing mean hemoglobin, mean ferritin levels that increase over the period of 12 months once you have fit in a Mirena coil. So then you might ask, Shazia, okay, what about, why can't I give them a pill and why should I put in a hormone? So I would argue with you that Mirena reduces the menstrual flow much more effectively and has a higher likelihood of treatment success than the oral medroxyprogesterone acetate. How about that? So there was an ECLIPSE trial, effectiveness and cost effectiveness of levonorgestrel containing system in primary care against standard treatment of menorrhagia. And look, with the usual treatment and with the levonorgestrel Mirena has been superior to the usual medical treatment over a period of 12 months to 24 months. Now, mind you, we are fitting in this coil for about 5 years. So of course, we talk about cost effectivity as well. And also one most important thing is that given the option of Mirena, like, I mean, if I am counseling somebody for heavy menstrual bleeding for a hysterectomy, have I given them all the options? Have I told them about this coil? So once they are told, a significant percentage, and this is a personal experience as well, would cancel their hysterectomy, would at least think about, okay, I want to have it fitted and I will see how things are in 6 months' time. And there's absolutely no harm in doing that. And you might be surprised to see that she did not need a hysterectomy after all. Okay, so we were talking about the irregular bleeding pattern, etc. So anywhere from infrequent periods to amenorrhea to regular periods. So this is what the lining of the womb, when the Mirena starts, reducing the lining of the womb, it will shed it bit by bit in the initial 3 to 4 months. And that when that is happening, that is the time that a person is having irregular bleeding. Now, if she talks to you about having to pray and having to fast, as you know, that you can explain to her 2 things. One is the difference between the menses, Hez, and istihaza. After, as you know, that after 15 days it is istihaza. The second important thing is that you can also add some add-back therapy. We'll talk about it in the next few slides to sort of combat that intractable bleeding for that period of time that she needs absolutely no period window, vis-a-vis Ramadan, vis-a-vis going for an Umrah, vis-a-vis going for any other pilgrimage. So do you feel convinced? Let's get down to the second challenge now. How to insert a Mirena properly. Now, because of the time deficiency, I do have a 5-minute video. We'll see how we go in the end, and I'll play that video for you more than happily. Please remember this, that a properly placed Mirena rarely ever gets displaced. And the people who have manufactured the Mirena have manufactured the model of the coil for you in such a way that the most important thing is that it does not get displaced. It is placed in horizontally. The shaft and the flange of the Mirena itself is in the way that it does not let you fray. Okay, so what's the third challenge? The practical tip for post-insertion success. That's the most important one. Somebody might ask you a question, I'm not really good at taking my pill every day, or what kind of side effect can I expect from my birth control? I don't want another baby now, but what if I plan to get pregnant later on? Or is there a birth control that can help simplify my life vis-a-vis not having to remember to take a pill every day? That's your place to talk about Mirena. And in the counseling, you have to say it is not very costly compared to oral medication. And when the patient say, doctor, I'm spotting daily, what to do? Or I have not had a period for months since I've had a Mirena, what to do? So these are your questions that you have to address beforehand, before fitting in a coil for them, that yes, it is very, very cost effective. And yes, there will be some irregular bleeding, but that irregular bleeding is because the coil is actually working for you. So the spotting after insertion or amenorrhea in 25% of women, as we said, the most important thing again is that we need to give them the booklet. And remember, this booklet, you don't have to find it from anywhere. When you open the box of Mirena, there is an information leaflet booklet in there. At the back of the booklet, there is a 4-month calendar which says tick the date when she had the Mirena fitted in, and let her tick when she had spotting, and let her color the circle where she had an actual bleed. And that will give some homework to the patient, knowing that what she is having. This is the known effect of that, not a side effect of that. All righty. So The irregular bleeding or spotting, as we all know, may last for 3 to 4 months. I normally add a progesterone or a GnRH analog injection to that. It just tides over the period and acceptance become a bit more appropriate. I haven't had to remove any Mirena, which I have fitted in. I'm in practice for about like 27 odd years, and I've been fitting in Mirena for almost 19 years now. I haven't had to remove a Mirena, you know, for somebody who has had a menorrhagia and came back to me, remove my Mirena. A, it's not working, or B, I'm having unwanted side effects. But again, that also depends on a lot of counseling that goes with that. The only one Mirena that we had to remove was that it went out itself, and then we had to fit in another one. Okay, so the fourth challenge, we were talking about the cost. You know, I mean, I work in private practice, so you might be interested in knowing how much it's a cost. You know, I mean, most of you may be working in the Ministry of Health. So the Mirena the cost is around 379 Rial, and the insertion is a mere 150. So an overall 529 Rial. And if it is put in for menorrhagia, it is covered by insurance. Vis-a-vis your oral progesterone for a month is a 53 Rial, for 6 months is a 318 Rial, and for a year is a 636 Rial. Now, 636 versus 529, mind you that this is a 5 years course. Okay, so, and also having to take 2191 daily pills over 6 years versus a Mirena. So not having to take a pill every day, again, that's also cost effectivity, that's also reliability, and that's also convenience of use. Now let's talk about, having done with the hemorrhagic bleeding, having done with the contraception, I would like to bring your attention to other indications of use of Mirena. Okay, we have been talking about endometriosis, long-term relief of chronic pelvic pain. It has a room for fitting in a Mirena to see if that takes, because what does the Mirena do? It does brings your periods to a bit of a halt. It does reduces the bleeding and hence reduces the dysmenorrhea and the cramping. So that there have been evidence of endometriosis pain being treated with Mirena over a long-term period of time. So might as well try this. The second thing is uterine myoma. Initially, it was thought that, you know, Mirena is not something if there are myomas inside the uterus. But again, for a patient with menorrhagia and fibroids less than 4 millimeter in size, a trial of Mirena is indeed recommended. And the response rate for Mirena on fibroids depend on the fibroid location. So the submucosal one, or if it is a unicornuate uterus with a size disposition, might not work effectively, but it's always worth a trial before sending such people for a surgery. Okay, endometrial hyperplasia. Now, we all know that there are 4 different types of endometrial hyperplasia. There's a normal proliferative state, there's a simple hyperplasia, there's a complex one, and then there is a hyperplasia with atypia, something that can get converted into cancer, with the risk of endometrial cancer. So if somebody comes to you with abnormal uterine bleeding and you have ruled out, you know, complex hyperplasia with atypia, what I normally do is I do an EUA examination under anesthesia, I do a hysteroscopy, which is a gold standard, I do a biopsy, and what I'm seeing, I put in a Mirena at the same time. So that's a gold standard of treatment. They come back in the next week, we get a normal histopathology. So we have actually seen, biopsied, treated at the same time. They go home, we see them in a month's time, we give them the diary, you know, for taking that pattern of bleed, and they're happy. They are really happy that their symptoms disappeared. Okay, so endometrial hyperplasia, the beneficial effects would be observed by 1 year, and the treatment should be reliably monitored. When I say reliably, do an ultrasound and do a Pipelle biopsy, endometrial sampling in the clinic as well, 6 monthly outpatient follow-up. Okay, breast cancer, tamoxifen and Mirena. Tamoxifen, as we all know, is the adjuvant treatment for estrogen receptor positive cancers. But the problem with the tamoxifen is you go for one thing, you get another thing. Tamoxifen can give rise to uterine polyp, uterine hyperplasia, and sadly, sometimes uterine cancer. So tamoxifen combined with Mirena in situ inside the uterus, Mirena can reduce the risk of having uterine polyps. Now, the Cochrane database systemic review does say polyps, yes, but about endometrial hyperplasia or adenocarcinoma, still larger studies are needed. Mirena and endometrial cancer. So endometrial cancer, as we know, is the most common gynecological cancer. Again, disease persistence is more common with the patients with hyperplasia. We do not recommend the Mirena as a primary treatment underway, but again, as the doctor from the UK said, there's a long waiting list, etc. You know, Mirena can be your choice, you know, while the patient is waiting, or just to see how the symptoms go. Okay, early stage endometrial cancer may have a role in selected patient, again, willing to preserve the fertility, endometrial protection for women on tamoxifen, women with clotting disorders, or on treatment for antithrombotic treatment. So all these are effective treatments for the use of Mirena. Now, there has been an advent, a propagation with low dose intrauterine system as well. We talked about 52 milligram of Mirena releasing 20 mics every day. There have been LNG 12 and LNG 16, which are now available by the name of Clibella and Jedes, and these are Kylena and Jedes, and Kylena is releasing 19.5 milligram and Jedes is releasing 13.5 milligram. So these are not available in Saudi yet, but the manufacturer did understand that the intractable bleeding or was a bit of a problem. So the low dose Kylena and Jedes are also available worldwide now to counteract that issue. Okay, this is the EVO inserter that we were talking about. So the duration of the Mirena, one important thing is that, the NICE guidelines says that it can be continued till menopause. If we are inserting the Mirena above 45 years of age and she has complete amenorrhea, it can be removed in the mid-50s, like 55 to 58, as long as it controls the bleeding. If we are using Mirena as a HRT arm, you change it after 4 years and it is licensed for the use. As a contraception, under 45, it's for 5 years, above 45, it's for 7 years. There are no significant drug interactions with Mirena. It has no change in blood pressure, lipid profile, coagulation factor, or carbohydrate metabolism, or liver function, or bone mineral density. But I do tell the women who have the Mirena inserted in, if they go for any surgery or anything, do tell their doctor that they have a Mirena fitted in. Sonographically, this is how Mirena looks on a regular ultrasound. It will cast an acoustic shadow at the bottom. This is Mirena again on a 4D scan. Again, the newer levonorgestrel system have a silver tip at the top so that it's more detectable on ultrasounds. Our personal experience with Mirena with hemorrhagic menstrual bleeding is 150 cases, 2 expulsions, 1 reinsertion, 1 TAH, 80% cure rate, prevention of TAH, and preserved fertility. Now, so the take-home message would be, this is a patient-friendly device. It is efficacious and it is viable to it is a viable alternative to surgery. So do think about that. Of course, there are less operative skills required if you know how to fit in a coil. And the manufacturer has made the applicator so easy and so user-friendly, single-hand approach. So it is very, the learning curve is very fast. There are no operative hazards, and contraception and preservation of fertility is a predominance. So my advice to all of us, it would be convince ourselves first. Hormonal side effects, irregular bleeding, menses or istihada, give written information, reassure about functional ovarian cyst. Mirena is a hormone. It can cause a functional ovarian cyst in right or left ovary. It does not go big. It does not cause any problem. When you remove the Mirena, it eventually dies off in a couple of months. So this is what the information booklet of Mirena looks like a 4-month calendar with the date of insertion. Put an X when you're spotting, put a circle, and when you're bleeding, just color that circle. So it's very important that you give this booklet to the patient, you put the date of insertion, and you discuss about these things in detail, this is also very important. So thank you very much. If we have some time, I would like to run that video for the Mirena insertion for you guys. Just bear with me for a second.
Insertion and removal replacement. Preparation for insertion. Examine the patient to establish the size and position of the uterus, and in order to detect any signs of acute genital infections or other contraindications for the insertion of Mirena, and to exclude pregnancy. Insert a speculum, visualize the cervix, and then cleanse the cervix and vagina with a suitable antiseptic solution. Grasp the anterior lip of the cervix with a tenaculum to stabilize the uterus. If the uterus is retroverted, it may be more appropriate to grasp the posterior lip of the cervix. gentle traction on the forceps can be applied to straighten the cervical canal. The forceps should remain in position and gentle counter-traction on the cervix should be maintained throughout the insertion procedure. Advance uterine sound through the cervical canal to the fundus to measure the depth and confirm the direction of the uterine cavity. If difficulty is encountered, consider dilatation of the canal. Insertion. First, open the sterile package completely. Then use sterile technique and sterile gloves. Mirena is provided within an inserter consisting of the Mirena itself, already in the correct horizontal position, an anatomically curved insertion tube with a double-sided centimeter scale and a plunger inside, the flange, and the handle containing the mark, the slider, and the threads inside. Push the slider forward in the direction of the arrow to the furthest position to load Mirena into the insertion tube. Do not pull the slider downwards, as this may prematurely release Mirena. Once released, Mirena cannot be reloaded. Holding the slider in the furthest position, set the upper edge of the flange to correspond to the sound measurement of the uterine depth. While holding the slider in the furthest position, advance the inserter through the cervix until the flange is approximately 1.5 to 2 centimeters from the uterine cervix. Do not force the inserter. Dilate the cervical canal if necessary. While holding the inserter steady, pull the slider to the mark to open the horizontal arms of Mirena. Wait 5 to 10 seconds for the horizontal arms to open completely. Advance the inserter gently towards the fundus of the uterus until the flange touches the cervix. Mirena is now in the fundal position. Holding the inserter in place, release Mirena by pulling the slider all the way down. While holding the slider all the way down, gently remove the inserter by pulling it out. Cut the threads to leave about 2 to 3 centimeters visible outside of the cervix. Mirena insertion is now completed.
Okay, so that brings us to the end of my talk today, and I thank you very much. And I finish it on this note that observation, reason, human understanding, and courage, these makes a good physician. Thank you very much for listening to me.
Thank you very much, Dr. Shadia, for your interesting lecture. It's my pleasure to introduce our next speaker, Dr. Abdulaziz Al-Ubaid. We can't without, whenever we have oncology or something to talk about oncology, would like to invite Dr. Abdulaziz Al-Ubaid. He's a senior consultant, gyno-oncology. He will talk to us about cervical cancer screening. He's the CEO for CARE. So it's welcome, Dr. Abdulaziz. It's interesting to hear from you, your talk.
Thank you so much, Dr. Samir. And it's my pleasure to be with you guys this afternoon. And very impressive attendees and impressive panel of speakers and lectures. So I'm not going to waste time. I'm going to go ahead with the presentation. And I'm going to try to make it as simple as possible because cervical cancer screening, what we should know about and why we're using this modality versus the other. So just before I go into the details, I would like to emphasize that cervical cancer remains the most common cancer among women living in developing countries. And this is because as a healthcare community, we don't have the infrastructure to detect this cancer at its precancerous lesion and eradicate it from this world. And it's a potentially preventable and curable cancer. And that's the most important thing about this cancer. We're not talking about other cancers like pancreatic cancers or ovarian cancer where we don't have the means to eradicate, but this is a cancer that can be completely eradicated depending on how well the healthcare system is And we as healthcare advocates, how can we advocate for this, for the treatment and prevention? It is a manifestation of an infection of a genital HPV, human papillomavirus infection. So it is a manifestation of an infection that women can acquire during their reproductive life. And it is, there are about over 500,000 new cases every year with 270,000 annual deaths. Most of these cases happen in the developing countries where the screening programs are not well developed. It is a cancer that is more prevalent in women in lower socioeconomic groups, and it is correlated with the first coitus. Almost always it's caused by HPV infection, and I'm talking about the majority of these cancers, the squamous and the adenocarcinoma. The other rare types I'm not going to touch upon here in too much details, but they are included in the screening, but not in the HPV era. Other risk factors include smoking, oral contraceptive use, other sexually transmitted diseases like chlamydia, HIV, immunocompromised patients, and patients with history of prior abnormal pap smear. What's tragic about this cancer is that it affects women at their reproductive life. And if we calculate the years lost of life among women who got the cancer, it's about 17 years of life lost for each patient. When we do the math about the global burden of the disease, and we calculate how many women years of life are lost because of this cancer, it's 3.4 million years. It's a lot. These women are our sisters, mothers, wives, daughters, and their lives are lost because of a cancer that can be prevented. The prevention is by detection of the precursor lesion. What's good about this cancer is that the cancer doesn't develop suddenly. It takes years and years for the cancer to develop, the precancerous lesion develop, and then it can be detected at this stage before it goes into cancer. The screening for cervical cancer by the pap smear has led to a marked reduction in the incidence of mortality of this tumor over the past 50 years. And the new vaccine, I'm not going to touch upon because it's not within the scope of this presentation. HPV, high-risk HPV types has been detected in almost all the cervical cancer cases. And again, I'm talking about the most common types, not the clear cell or the small cell carcinoma, but the squamous and adenocarcinoma. 99.7% of these cancers had high-risk HPV types, and even the 0.3% which was not detected, it was confirmed by an expert histologic review. Even the HPV, the high-risk HPV, has been detected in the lymph nodes for the patients who had cervical cancer with lymph nodes metastasis. As a gynecologist, I'm proud that the pap smear is the most successful screening tool that has ever been developed in history. And it was named after its inventor, Dr. George Nicolaou Papanicolaou, who was born in Greece, and he started his work at the beginning of the last century. In 1928, he presented his first findings that the uterine cancer can be detected by means of vaginal smear. This is Dr. Papanicolaou. And in the 1940s, he started writing about the pap smear value, and it was published at the American Journal of Obstetrics and Gynecology. And once he got his work published, a huge attention came to this paper, and it was adopted as a tool to eradicate this cancer. And since World War II, the pap smear test has become the most successful and widely used cancer screening method in the world. I'm going to talk about how we do the pap smear. I still do the conventional smear with the wooden spatula and endobrush to the endocervix. And the reason is during my training, the liquid-based cytology came, and it was introduced in the 90s and became the screening method of choice in most of the centers across the countries. And everybody was shifting towards using the liquid-based cytology. There was a lot of pressure from the cytopathologists that the quality of the smear is better, and there is the interpretation is easier, and you don't have contamination of vaginal secretions that limit your interpretation. However, a systematic review came in 2008, and it was found that the liquid-based cytology does not lead to more disease protection. And not only that, but it increases the false positive testing. False positive testing comes with a value, with a price. So if I tell the patient the cytology is positive, it means that she needs further testing. She needs to be referred to colposcopy. It has a psychological trauma to the patient's effect. And there are more resources that are wasted for no reason. The liquid-based cytology was more likely to be interpreted as abnormal or equivocal. They did not lead to more detection of high-grade CIN, despite that they had more false positive results. The benefit of fewer unsatisfactory tests does not justify the use. That's the conclusion of the meta-analysis. And not only that, but there was a comment by Sawaya in the same journal at the same time when this was published, that this article stated that the saga of liquid-based cytology is to be added to the list of cautionary tales in women's health. We have an obligation that as scientists, I think physicians are scientists, and they have to accept that not everything that comes out and gets pushed by the industry means that it is the best tool. We have to evaluate and decide what's best for our patients. So I'm not only talking about the cost. The wooden spatula is much cheaper, but also there's absolutely no benefit of the liquid-based cytology. So in my practice now, I completely stopped using the liquid-based cytology years and years ago. Just a follow-up on the abnormal pap smear. So when you have an abnormal pap smear, you refer the patient to colposcopy. Colposcopy is examining the cervix with magnification, applying the acetic acid, and trying to detect where is the lesion. The role of the colposcopy is to rule out cancer. And I'm not going to go into further details about the colposcopy because it's beyond the scope of this presentation. Now, there are so many guidelines, so I can't cover all the guidelines, but I decided to talk about the most recent guidelines that were published, and it is by the American Cancer Society. It came up in 2020. These are the 4 recommendations, and it's a busy slide, so I'm not going to go through all of it. I'm going to focus on the difference between the new recommendations versus the old ones. The old recommendation came in 2012, and the new recommendation came last year. So in the past, we before even 2012, we used to screen patients for cervical cancer. We do the pap smear at the time of their first coitus. In 2012, the recommendation came that we have to do it starting at the age of 21. The new recommendation now is that we start at the age of 25. So we don't have to do screening before the age of 25. This came because of a huge data that came out from the Scandinavian countries, especially Denmark, that shows that most of the infections and the changes that happen before the age of 25 are transient, and women will usually clear these lesions by their own immunity. Detecting them puts an obligation on the physician and the patient to do something about it. So it leads to unnecessary intervention, treatment, and not only the cost is higher, but again, there's a psychological impact, and there's a morbidity of the treatment. I mean, if you do a conization or LEEP, it comes with its own complications. So now we only start the screening at the age of 25, regardless of what the first coitus when it happened. In 2012, the recommendation is that we do a pap smear, a cytology alone, every 3 years until the age of 29. And that HPV screening as a primary tool is not recommended. This has flipped completely. Now the recommendation is the first tool of screening should be the HPV DNA testing. And we do it at the age of 25 up until the age of 65 years of age. We do it once every 5 years. So you do HPV testing once every 5 years. If it's negative, you don't have to do anything. If HPV is positive, then you refer the patient to colposcopy. Cytology co-testing with HPV is acceptable, and you still can do it every 5 years. Cytology alone is acceptable, but you have to do it every 3 years. Now, this recommendation will be changed in the future, where cytology will not be accepted, and HPV DNA only testing is going to be the method. It's going to come soon enough. This has changed the way we deal with cervical cancer. Above the age of 65, you can stop the screening if the patient has either 2 negative HPV testing in the past or 3 consecutive negative pap smears. And this has not changed from the previous guidelines. And after hysterectomy, you don't have to do screening unless the patient had history of precancerous cervical lesion. So these recommendations actually are quite interesting, and I think we should adopt them as soon as possible. Cytology is much cheaper. The cost of doing the pap smear, cytology smear, and sending it to the lab and having it interpreted, it's much cheaper than the HPV. However, the HPV testing in the United States, if a patient doesn't have insurance, is about $30, which is slightly above 100 riyals. So it's much more.
It seems the connection with Dr. Abdulaziz was cut. So sorry for that.
Yeah. Sorry?
Now we can hear you again. Please continue.
It requires an infrastructure investment where you have a central cytology lab where the patient can be called for their pap smear and their cytology. And that's the major barrier where that prevented the prevention of cervical cancer. It's not the cost of the screening test, which is very inexpensive, but it is the cost and the complexity of the infrastructure. So even in developing, if a developing country decided to do the cervical cytology program, it's not enough to do the screening once and then the patient will not come back. You have to have a robust program where you call the patient to make sure that they come for their subsequent tests. If you remember, probably 10, 20 years ago, 10 or 15 years ago, we used to do the PAP once a year. And the reason for that is that the sensitivity is about 50%. What does this mean? You will miss 50% of the patients that have lesions. And if you miss 50% of the patients, you will catch them when you repeat the cytology. So you will cover 75%. And then when you do it the third time, you will cover over 90% of the patients. And that's why the cytology has its own limitations, because you have to do it subsequently. Doing it once does not carry value because you will miss 50% of the patients. Where in HPV testing, the kits that were developed will cover all the high-risk oncogenic genotypes, the high-risk groups for detection. And these HPV genotypes testings is very easy to use, and even now it's, the patients can use it on their own, so they can just bring the kit to the lab and the lab can do the testings. The sensitivity is over 90%, so it's much better sensitivity than the cytology, and that's why we do it once every 5 years, because if you detect it, you will deal with it. And if you don't detect it, then the patient is fine for 5 years. Someone might ask, well, what if she develops a new infection after the screening was done? It takes years and years for that new lesion to develop into a precancerous lesion. So 5 years is a good window to repeat the HPV typing. In Europe and the United States, most of the countries have shifted to HPV DNA testing, and I believe that it's going to become universal. I went through some of the slides while I was speaking, so that's why I'm going over them fast, and I have only 20 minutes. So now the Melinda and Bill Gates Foundation are developing a cheaper HPV test that can be donated to the developing countries where the magnitude of the disease and the morbidity is highest. Talking about our country, I've been through so many talks about cervical cancer with individuals in key positions at the Minister of Health or the regulators, and the argument that I always have when I speak about cervical cancer and how can we eradicate it and prevent it is that it does not have a high magnitude in the country. In Saudi Arabia, the numbers are low and we don't need to do anything about it presently. My counter argument is, this is the cancer that you can prevent completely. This is the cancer that you can eradicate. So just because we don't see it every day does not mean it doesn't exist. And unfortunately, what we see now is that we have more and more cases. I'm not going to go over why we're seeing more cases. I think people can make their own minds about why we're having them. But we still have the problem and it still exists. And I would like to add that it's more than what you think. This is a paper that I was fortunate to be part of back in 2014. We did a study with a group of colleagues from the National Guard and King Faisal Specialist Hospital when I was at King Fahd Medical City. And we looked into the prevalence of HPV among women who come for the gynecology clinic with a complaint other than that can be related to cervical cancer. So those who come with vaginal discharge, itching, we excluded them from the study, but those who come for checkup or if they have irregular bleeding or if they come for another reason, we do the screening for them to see how many of them have HPV. And to our surprise, it was about 10%. 10%, 9.8 to be exact, of women had positive HPV in the clinics. It was highest among women who were above 55 years of age and higher in the non-Saudi nationals. There are many studies that talked about screening in cervical cancer. So what's the incidence of abnormal pap smear? And most of the studies were retrospective. And the rate of abnormal pap smears varies between less than 1% to up to 18%. However, the only prospective study, and it was on a very high number, was published by Dr. Fadwa Altaf, I believe, from King Abdulaziz University in Jeddah. And more than 5,000 patients, the percentage of abnormal pap smear was 4.7%, which goes with the international usual figures. and the recommendation of all those who performed these studies was that we have to develop a national screening programs. Now, these recommendations have been repeated over the past 20 years, and we could not develop a national screening program. I'm not blaming anyone. As a physician, as a gynecologist, I'm part of the problem, and I hope to be part of the solution in the future, inshallah. Another argument is that if the incidence is so low, why do we have to worry about it? Well, the problem that we don't have a screening programs is that we don't prevent the cancer. But not only that, when we detect the cancer, it's usually too late for a curative treatment. So most of the patients come when it's stage 2 and above. And this is a paper that was published more than 20 years ago from King Faisal Hospital by Dr. Manji. He was a radiation oncologist, and he compared the distribution of the cases with BC, British Columbia. 60% of the cases in British Columbia were at stage 1. This is where most of the cancers can be cured. In Saudi, less than 40% of the cases were at stage 1, and more cases were in stage 2 and 3. And that's the case. These are the patients that require more costly treatment that has higher morbidity and less success rate in cure. So in summary, cervical cytology carried out once has a sensitivity of 50%. So just because you do the screening once does not mean that the patient is protected for a longer time. You have to repeat the cytology, but the new recommendation is that you repeat it once every 3 years. And I do encourage all my colleagues to take the opportunistic advantage when the patient for whatever complaint and offer her the cervical cytology, even if it is done once. It's better than not doing it at all. High-risk HPV DNA testing is now the screening modality of choice, and the sensitivity is much higher than the cervical cytology. As a take-home message, I would like to repeat this slide and emphasize that we don't have to do screening before the age of 25. If you have high-risk HPV testing, it is the preferred method, and you do it once every 5 years. If you don't have it, cervical cytology alone is accepted, but you have to repeat it every 3 years. So that has changed from the previous recommendations where we start at an earlier age, and high-risk HPV testing was not considered as an acceptable method. So with that, I would like to conclude, and thank you all for giving me the opportunity and for your time.
Okay, thank you so much, Dr. Abaid, for this is very informative lecture and very hot subject, especially for young generation. Our next speaker, it's my honor to introduce him. He's Dr. Prof. Hassan Abdel Jabbar. He's my teacher. He's well known through among gynecologists in Saudi Arabia and outside. He's the president of Saudi Society of Obstetrics and Gynecology, and his talk will be about what is cosmetic gynecology. Dr. Abdel Jabbar.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
Thank you very much for nice introduction. After all the diseases that we have, and after all this, I don't know what to talk about. So I decided to talk about something called cosmetic gynecology. And for two reasons. First, cosmetic gynecology is a new branch, actually. It's now becoming part of the urogynecologists. But unfortunately, a lot of people, they started to do cosmetic gynecology, maybe without having good knowledge about it. So if we look at Google, our famous Google, we will find that 9 million people, they would love to know about cosmetic gynecology. And this was like about a year ago. And if you look at the PubMed paper and publication, it's only 32. It means that a lot of these things are maybe not scientific, could not have good scientific evidence that it can be published. This is just a few hours ago, not last year. It became 11,400,000 people, they wanted to know about cosmetic gynecology. But fortunately, the people, they started to do more research about it, and now we have about 900 publication in the National Library of Medicine. If we ask people what is cosmetic gynecology, only 57% understand the definition of cosmetic gynecology. 14% they define it as vaginal rejuvenation surgery, or vaginal tightening and vaginal laser only. Cosmetic gynecology referred to an aesthetic surgical correction and enhancement of the genital structure. It has been very popular in the media, and this is to make improvement to their physical appearance for women and the function of the vagina and labia. And cosmetic surgery is a type of plastic surgery. It is a plastic surgery aimed to improve the person's appearance, but it would not be approach. It should be approached with caution. If we think about cosmetic gynecology, let's think about cosmetic gynecology. We will find that it's very important to have a good consent when you do cosmetic gynecology. The doctor will carry out the procedure, must speak personally with the patient. You cannot let your resident or specialist or registrar to talk to the patient. You have to talk to him personally and explain to him everything, to her everything. You have to be open, and you have to very safe, and it is not a big hospital, but a safe place, suitable, and a good environment. The marketing should not be marketing mukhada. The doctor must market their service responsible to be clear about the risk involved. The doctor should have experience of carry out the procedure and patient ask for, and you don't give him more or less. You have a decision whether he should do the procedure, not of doing it or not. The information, the doctor must give clear information, including detail about aftercare. Aftercare is very important in plastic surgery. Maybe the plastic surgeon, they know that better than we do. And the cost must explain to the patient clearly, especially his fee, the doctor's fee, and how much money he's gonna have, and potential about the cosmetics. If we ask a youngness to perform cosmetic surgery, anybody like to do this? Only 40% of the new graduate would like to do it. 24% somewhat likely to do it. 27% they are non-certain, and about 40% they don't want to do it because they think that it's almost like a plastic surgery, and the expectation of patient is very high. Please do not put the financial gain, which is #1 reason for performing cosmetic surgery, because maybe if you have a problem with one cosmetic surgery, maybe you spend a lot of money trying to treat the person. Who should perform cosmetic surgery? 51% now. About 50% they are general OBGYN. They're not specialized in urogynecology. Only 25% they do in urogynecology. Plastic surgeon, 21% doing plastic surgery. I've been in some of the country, and dermatologists, they started to do cosmetic gynecology as well, which is maybe not fair because the anatomy in that area is different than the face anatomy. If we ask the trainee how much of the training of cosmetic gynecology in the training of OBGYN, we will find no training at all. Maybe 9% in some of the high caliber training center, they will have a very small amount of training on the surgical cosmetic gynecology, but not non-surgical. The American College of OBGYN opinion regarding the cosmetic surgery undetermined, 32% they're against, and 25% they have no comments about it. Regarding vaginal rejuvenation, which is the first cosmetic vagina, the American College of OBGYN decided that it's not a surgical procedure. About it in a minute, I'm going to leave this, but I will just give you some in millimeter, what is the width of clitoris, what is the length of clitoris, labia majora, that this procedure is an art. You have to be an artist to do the procedure. You have to know the
I think there is a problem in your voice, Dr. Hassan.
I think he lost the connection, Doctor.
Sorry, I have. Yep. I'm back.
This is part of cosmetic, Prof. Hassan.
Yes. You're sorry. Now is it okay? Is it okay now?
Yes.
Is it okay?
Yes.
Aywa.
It's okay now. Okay, then women would be lack of data support the efficiency of the procedure of their potential complication. And you have to tell them about the complication because these complications are very important, like if alteration of sensation, dyspareunia, adhesion, scarring. Patient has to know about it. This is how you can see before and after. I'm sorry about the picture, but this is the only picture I could get. This is how bad it was before surgery. This is how good after surgery. This is a lot of people, I'm sure a lot of gynecologists will see cystocele and rectocele, and after repair, they will become better. This is part of the cosmetic surgery. This is another one, rectocele, which is very obvious. There is so many surgical procedure. I will go through them quickly. Clitoral hood reduction. في بعض الأماكن يسموها circumcision, but it's really not a circumcision. Surgical procedure, clitoral hood reduction. The problem, if you look at the end of my slide, you'll find scarring, infection, hematomas, hypersensitivity, damage to the glands. These are, it's a very small procedure, but it can give you a lot of complications. Lipoplasty is the commonest surgical procedure done for cosmetic gynecology. It's eliminate unwanted tissue for the labia minora. If the labia minora is more than 6 centimeters, it's considered to be big. There's so many types of trimming and the edge, wedging the resection, Y-shaped incision, zeoplasty, and all these we took it from the plastic surgery. Type of procedure is like labia majora augmentation, and this is by filling you either autologous fat transplant or injectable fillers like hyaluronic acid. Sometimes it can cause palpable fatty cyst under the skin. Hymenoplasty to reduce the vaginal status. Reconstruction of hymenoplasty is not done, but in some practice people they do it, and it can cause wound dehiscence, and it will be worse than before the surgery. Vaginoplasty, tightening the vaginoplasty, either by anterior and posterior corporaphy, augmentation, restoration, or using energy device, based device. All of them, they can lead to infection, dyspareunia, dehiscence, and sometimes even fistula. Laser radio frequency can cause burn and can cause recurrent chronic pain with sexual intercourse. Injection, there's now a new method of augmentation of the G-spots to become more sexually acceptable by either autologous fat transfer or hyaluronic acid. And it can be used sometimes by even the urologist. Unfortunately, can cause urinary tract infection. Labioplasty is the most common cosmetic surgical procedure. Is usually done by the gynecologist. This is the only one which is done by a gynecologist, sometimes by a plastic surgeon. And this is just before and this is after. Why people they do such a procedure? 87% purely cosmetic. 64% sometimes they do it because they found difficulty in wearing their clothes, discomfort during sport in 25%, and dyspareunia in 43%. On the other hand, there is pelvic support defect like cystocele, urethrocoele, rectocele, enterocele, and uterine prolapse. And this is why we said it's partly of urogynecological subspecialty. The major cause of pelvic floor defect is, of course, childbirth, chronic cough, heavy lifting, and sometimes just weakness from the congenital weakness of the tissue. Vaginoplasty and perineoplasty are the most commonly procedure done as a pelvic floor defect. A lot of study of female genital plastic surgery show that the enhancement of the self-esteeming and the function improved after cosmetic surgery. How much improve? It's not really consistent. Sometimes the improvement is 25% and sometimes it's 100%. Complications were minimal, relatively short-lived, and it's like 91% over satisfaction rate. The enhancement of sexual pleasure is 90%, and 80% of their partners. You know that there is Indiag and Eriag laser has been treated. They are really satisfied. But this is an average pelvic floor muscle. This was published. Vaginal canal, 10% urinary incontinence patient were urinary. The laser are very good if you know how to use it. If you don't know how to use it, you might have complications. You know that we have been using but we use it in condyloma, cervical dysplasia, vulvar melanosis. We use ovarian disease in cervical and endometrial polyp, for liposuction and of Monas pubis. There is a need for guideline. There is a need for indication. There is a need for complication and long-term complication. And in my last slide, this conclusion, I heard that Saudi they wanted to stop cosmetic dermatology because the cosmetic gynecology has a lot of complications, and there is a lot of, maybe they after that they will put guidelines, they would tell the indication for it, what are who will do it, where they should do it. It's exactly what happened with the laser rejuvenation. When it came to the kingdom, everybody was doing it. They're doing it in small dispensaries. They became very cheap. But now I think with the Saudi Food and Drug, they put criteria for people who should do it and where should be done. And hopefully we will have no complication from cosmetic gynecology, because cosmetic gynecology, it means that للتجميل وليس للتشويه. والسلام عليكم ورحمة الله وبركاته.
Thank you so much, Prof. Hassan, for a very nice lecture. And our next speaker will be Dr. Salwa Bahkali. Dr. Bahkali she's a co-chairman of Middle East Association of Aesthetic Medicine and Reconstructive of FMG, Female Genital Mutilation Surgery, North American Academy of Aesthetic Medicine, international trainer. She will talk about quality versus quantity in the providing urogynecology and cosmetic gynecology services. Dr. Salwa?
Thank you very much, Dr. Jihan, and I would like to thank the organizing committee for giving me the opportunity to be one of the speakers and share my experience with the webinar. We will talk about quality versus quantity when providing any gynecological or cosmetic gynecology service. It's a big topic, but I will go through it quickly, and we can discuss it in detail in the future if you like it. We know that urogynecology service is one of the most patients' needs in our community. But cosmetic gynecology service become also one of the interested fields and one of the most customers' demands. It's one of the fastest growing subspecialty in medicine. Why is that? Because the desire of the female to be beautiful and improve her genital appearance and function to satisfy herself and her husband result in this increase of demand for cosmetic gynecology service. Nowadays, a lot of females seeking for vagina rejuvenation and augmentation, in addition to urogenital problem, regardless to the age of or the culture. The attitude and behavior change if we compare it before 10 years. As we know that the old generation were ignoring any urogenital problem, especially in the appearance or in the shape, but they care about the vaginal laxity, they care about the prolapse, the incontinence. But nowadays, the new generations, they care about the shape, they care about the color, the appearance, in addition to the function. We have to realize that the cosmetic gynecology service, it's different than other specialty. A lot of many people, they think that it's a luxury or fantasy. It's not a luxury or fantasy, no. We are aiming for functional rejuvenation and regeneration, in addition to restore the shape and contour of the area. But other specialty, they are aiming only for restoring the shape and the only and the contour. Some of them, yes, they care about the function too. As a gynecologist, we can deal with the three type of problem. Either the patient come for pure gynecological or urogynecological problem, or she may have a sexual problem related to urogenital system, or she may complain of cosmetic problem at the genital area, or mixture of this and that. And as we noticed that, I think most of us knows that in our daily practice, the most four common issues related to urogenital and sexual function are the vaginal laxity, the urine incontinence, the decrease or loss of sensation during sex, and the dyspareunia. And if we are dealing with cosmetic cases, you will notice that the five most issues of vulvovaginal appearance is related to color, shape, size, and symmetry. But whatever was the problem, most of the patients or customers, if not all, who is seeking any cosmetic gynecology service or even urogenital problem had a hidden agenda. Most of them, they care about their sexual life, or they have sexual problem, except those ladies who are non-sexually active, not active, or ladies who have incontinence or severe prolapse. The patients may have any functional or aesthetic problem which can interfere with her sexual or social life. And by correcting the problem, we can improve the patient's condition and increase her sexual self-esteem and self-confidence. And how can we do that? We can do it by offering one of the available cosmetic procedure to treat the condition and to restore patient urogenital function. We have a wide range of invasive, non-invasive, and many invasive procedures to play with and providing pioneering urogynecological and cosmetic gynecology service with a good outcome. But before we decide what to do, we must stop for 1 minute and evaluate three important issues. We have to evaluate the quality and the quantity of both the treated and surrounding area, and in addition to the pelvic muscle support. Why is that? Because we know all that as we age, the quality of the skin and vaginal tissues are deteriorating. We know that the collagen and elastin start to be hardened and fragmented, so the network start to break down and the skin and vagina start to lose its support and elasticity. What about the microcirculation, the blood? The nutrient, it decline. So the nutrients may not reach the area and result in unhealthy skin or unhealthy vagina. Not only that, but the erectile tissue will not engorge during intercourse properly, which results in sexual dysfunction or unsatisfaction. Also, the nerve conductivity will be the nerve will be affected by age, and the nerve conductivity and sensitivity will decline too, which may affect the sexual function negatively. Another thing to happen, the fatty layer beneath the skin becomes thin and the area start to be sagging. So if we limit ourselves doing invasive surgery only, we will improve only the quantity, which means we will improve the size and the anatomical position of the tissue or organ, but we will not improve the quality of the treated area or the pelvic support. For example, if we do only vaginal repair surgery, we will decrease the caliber of the vagina. So this is a quantity. But what about the quality of the tissue? Suppose the tissue, the patient have vaginal atrophy. Suppose there is any problem with the tissue, we will not improve it by the surgery. Okay, and if you continue doing that, what will happen? The case may relapse again or deteriorated with time, and we don't want that to happen. So even if we are still work or we just want to work as a gynecologist and we are not interested in cosmetic or treating sexual problem, we have to think now in a different way and upgrade our practice. We have to do whatever we do in a great way. Whenever we deal with any case, we have to think about longevity. In terms of we want to have the optimizing result. We want to restore the function of the organ or the tissue. We want the patient satisfaction rate to be high. And also we have to do our best to avoid relapse of the condition or any deterioration. Have you ever asked yourself why after doing a successful anterior vaginal repair or colporrhaphy, either by you or by your colleague, the patient may come after a couple of years or after 5, 6, 7, 8 years again after, and then she complain of the same problem, even if she didn't get pregnant or she don't have any risk factor. Why that happen? Because that will happen if we ignore the quality of the vaginal tissue and the pelvic floor support. So during my practice, I realized that in order to achieve the best results in terms of longevity, I should work in 3 dimensions. I make my own approach. I call it the triangle of effectiveness. In this triangle, I always work in 3 sides and angles of effectiveness triangle. First, I look after the quantity, the tissue quantity, by correcting the size and anatomical position. And also, I will work in the tissue quality by improving and enhancing the collagen formation. I will look after the nerve functions and conductivity, as well as I will enhance also the microcirculation at the treated area if it needs, and regenerate or rejuvenate the epithelium. Not only that, but I will not forget the 3rd side of the effectiveness triangle, which is muscle tone. I should strengthen the pelvic floor muscle. Okay, so the question is, how can we improve the quality of the tissue? We can improve it and achieve that goal by using any of the non-invasive or mini-invasive technique, either alone or in addition to surgery. And we know most of the non-invasive and mini-invasive technology will improve the 3 main elements at the treated area. It will improve the collagen and elastin, as well as the nerve sensitivity and the microcirculation. Okay, we can improve the quality of the tissue by using one of the energy-based devices, such as radio frequency, laser, HIFU, anyone. But I prefer using radio frequency because I will have many options and application in radio frequency to work with at the genital area. Not only that, but I can work with transcutaneous radio frequency safely on the erectile tissue to enhance the sexual function, either outside or inside the vagina. But I cannot do that with the laser, with the HIFU. Okay, so with energy-based devices, as you see here, it will help in tighten the reduction of the vagina diameter. This is the diameter, now it becomes reduced. And also it will improve the thickness. Here, it is very thin, and here it becomes thick. So we have to think about it seriously. We can improve also the quality of the treated area by using injectable regenerative products such as BRB, which is platelet-rich plasma, platelet-rich fibrin, or stem cell, mesotherapy, carboxytherapy, any other technology. We have a wide range of technologies. Nanofat considered to be one of the best mini-invasive technology to improve the tissue quality because it's rich of stem cell, but we cannot use it in the whole vaginal caliber as we can do with the energy-based devices. So with the radio frequency or energy-based device, we can tighten the introitus and vaginal canal and improve the stress incontinence in case of the mild or moderate degree. But also we can use it to relieve the related menopausal, the local related menopausal symptoms. Also, we can help in enhancing the sexual response and help female to reach orgasm through the G-spot clitoris by increasing blood flow and increase the sensitivity and nerve conductivity to improve the orgasm. Also, we have something called injectable radiofrequency. We do it by fractionated micro needling radiofrequency devices, and this is one of the best technology of improving the intimate skin quality. It improves the firmness, it improves the shape, the appearance, the color. Not only that, but we have another injectable radiofrequency which is called Aviva Acutite. This is a new innovation technology to improve the quality of the treated tissue in depth from outside and from inside. And it can be one of the best solutions to be used in the mild or moderate labia, hypertrophy, or skin sagging instead of surgery. Okay, so the other questions, how we can improve. What about the third side of the effectiveness triangle? How can we improve the pelvic floor? We can, of course, we all agree that pelvic floor muscle laxity play an important role in all urogynecologist problem, including urine incontinence. And we can improve most of the urogenital conditions by strengthening the muscle either alone or in addition to other treatment. For example, in urge incontinence, there is inappropriate and involuntary bladder contraction, while in case of stress incontinence, there is a weakness either in the pelvic floor muscle itself, which support the bladder, or in the muscles which do the squeezing. So the muscle is an important element to treat it if a patient had incontinence. That's why we always advise the patient to do Kegel exercise, even if we do surgery. But unfortunately, the wrong way of Kegel exercising will not produce the optimal result only, but it can also train women to become dysfunctional voiders. So we have another option, the electrical stimulation. It's a good choice for strengthening the pelvic floor muscle, but it could be annoying and can cause discomfort or irritations for many patients. And sometimes now there is a chair, even electrical stimulation chair. But if we compare it with the high intensity, the electromagnetic chair, this is different than this. The electromagnetic chair will be better because it can go deeper, the stimulation. That's why when we use the electrical stimulation technique, we need longer time to see the result. But with the high intensity, this is the new technology, with a high intensity focus electromagnetic technology, we can have faster regeneration of the muscle and other tissues or of the pelvic floor. We can see the result within 3 to 4 weeks, but because it's extremely powerful focus field, it can reach the supramaximal muscle contraction and to improve the muscle, the hypertrophy, the stimulations, everything in the muscles. While the patient is sitting comfortably on the electromagnetic chair on the Emsella applicator. And one of the good advantage of this magnetic stimulation chair is that the patient can learn the proper implementation of Kegel exercise through the therapy. Also, she can continue to carry out these exercises at home. So our goal from this electromagnetic chair is the therapy, is rehabilitation of the pelvic floor muscle to reduce urinary incontinence, also to improve the pelvic organ prolapse, and to enhance sexual function. And we all agree that the general strong pelvic muscle can help not only in treating or improving the incontinence, but it will help in maintaining urinary and fecal continence, as well as enhance sexual pleasure. So, as we see, most of the urogynecological problems that we face in our daily practice, we can help the patient by using energy-based devices, by using radiofrequency, by using injectable line, in addition to Emcella chair. But we have to remember that the timely initiation of the treatment before the mild and moderate incontinence progress to severe problem is extremely important. And the success of timely treatment with non-invasive method is more efficient and sustainable than doing surgery alone. And I think if we do that, the surgical treatment can be avoided or at least postponed for several years. Okay, so what about the aesthetic or cosmetic? It's the same meaning. We have to apply the same principle and the same triangle of effectiveness when we are dealing with any aesthetic or cosmetic case. We should think about first, what and where is our target, to identify our aim and to which level we have to reach to achieve our goal. So accordingly, we have to choose the suitable energy-based devices and the level of energy that we need to have a good result and to decide what to do. But whenever we decide to select energy-based device, we must always think about safety and effectiveness. We think about safety and effectiveness. So for safety and effectiveness, radiofrequency is one of the best options. But remember, not all radiofrequency devices or energy-based devices work the same or give the same result. We have to if we decide to work with the energy-based device, we must look for the devices or machines that apply something called ACE principle. This is mean acquired, control, and extend. Acquired means to give us that device, we wanted to give us the optimal therapeutic temperature for collagen contraction, which is 38 and above. We don't want less than that. At the same time, we want to control this emitted temperature to be controlled through the cutoff operating program setting. So we want to avoid the complication. Also, sometimes we want to extend our therapeutic temperature for some period to achieve the ideal thermal endpoint. So we want that device to give us this feature. So we have to remember that different energy-based devices have different modes, and each mode can be used for different application. I have about 7 to 8 years experience in the field of cosmetic gynecology, and from my experience, I can say that radio frequency is safer than laser. I start with laser, but most of the procedure done with radio frequency need longer time compared to laser, because laser more aggressive, but it needs more experience. Not only that, but the radio frequency devices, especially the new technology, give us more than one options to play with. For example, Fotiva and BodyTite radio frequency device by Mod, it is one of the best radio frequency devices, if it was not the best until now. It applied the ACE principle, and I really like this device. Why? Because with Fotiva radio frequency, I can work, I can reach any level I want, and I have amazing result. For example, if I want to rejuvenate and treat the skin pigmentation or resurface of the intimate area, I can work on the epidermal level safely with no or very little risk of hyperpigmentation, which is usually happen with laser. And if I want to tighten the skin or reduce the laxity, or if, for example, if I want to enhance the microcirculation, to enhance sexual function, I will work with the dermal level. At the dermal level, also with Votiva. Also, sometimes I want to work at deeper level, at subcutaneous level, and I can do that with Votiva. You can use any device, not only Votiva, but whatever, but choose the device that apply the ACE principle, and don't stuck in one platform or one mode device, because with different type of radiofrequency devices and technology, we can offer pioneer safe surface for almost all skin type of patients. And you know, in Saudi Arabia, we have the skin type 4 and above, which is risky for all cosmetic surfaces. So we have to improve, we can use those devices in most of our cases. But we can treat those devices. It cannot treat the severe laxity or severe incontinence or sagging, but it can help. This is a collection of transcutaneous radiofrequency devices. These two of them, they are approved by Saudi FDA. It's BTL and Votiva. But I work with these devices outside the country, and I have a good to work with, transcutaneous inside the vagina, and I have a good result with them. And this is another collection of fractionated and microneedling radiofrequency devices, all approved by Saudi FDA. And this is the mini invasive radiofrequency device. This is fractionated. This is a mini invasive. It's a unique radiofrequency device, and it is approved by FDA. I can say that 1 + 1 will equal to 3, 4, 5, 6, 9, not 2, when we do combination therapy. And sometimes it equals more, because I believe that when we apply different devices with different features and different technique, we can obtain wonderful results in terms of restorations and rejuvenation, because each one will be an additive and synergistic effect with the other one. And that's why I like Votiva radiofrequency device, because it's 3-in-1. This is 3 applicator, 3 platform in one devices. I can use most of these platform in almost all my cases, and it is very safe and very effective too. This is some of the sorry for the pictures, but this is the photos. But this is some of the photos before and after. But this is not my photos. This is the photos to people who I work with. This is for Viva, and this is here in the middle. This is we use for Viva transcutaneous for 7 minutes externally, and this is we use the micro needling radiofrequency, and this is another one for Viva, the transcutaneous one. This is before and this is after, and this is also another one before and after. Look, this is very amazing with this result. That this lady, she needs surgical treatment, but even it improved. Look, you see, this is before and this is after. It's improved by using the 3 platform of Votiva. And here also the conditions improve after 4 weeks, and this is after the second second session with the Votiva. And this is also notice the difference. This is by using Aviva Aquitite without surgery. It's really amazing. So I conclude that my triangle or the triangle effectiveness for management urogynecological and cosmetic gynecological cases, I think it's a cost-effective and safe approach to guarantee the best realistic result and to assure the maximum longevity of the patient satisfaction. Also, we can take help or we can take an advantage of these new devices, the electromagnetic chair, which is a new innovative method for pelvic muscle support. So it will allow for faster recovery with no pain compared to the standard Kegel exercise or electro stimulation. Thank you very much, and I hope you enjoyed.
Thank you very much, Dr. Salwa, for your interesting lecture. I think it gives a lot about cosmetic gynecology. I think we have a shortage of time of lecture, but what of questions? So I would like to open for all the speakers to open the camera, and if they have any questions they want to ask each other or they want to say anything, so please do. Any questions from any of the speaker, please?
Oh. How can I close my share this one slide?
It's okay. But do you want to add anything, Dr. Salwa?
No. I want to add a lot of things, but no time.
Okay, thank you. It's really interesting lecture, and you see that the participant until now we are more than 2,900. They are hearing actually the lecture. So starting from 2 until now, they are all online hearing the lecture.
I just want to add one thing. Believe me, it is not a cosmetic gynecology. It is not only a cosmetic gynecology, but really we have to apply this. We have to work on the 3 triangle. We have to work on the quality of the tissue and also the pelvic support, not only restricted to the surgical or just to increase the size, to have a very good results.
Great.
Dr. Shadia, do you want to add anything?
No, thank you.
Or any
Dr.
question
This was beautiful. And just as you correctly pointed out that, it's literally with the younger generation, it's like literally an epidemic of cosmetic gynecology. So what do you feel, for the young gynecologist, what is the message? How many years or how many minimum years or months of training do we need to train a young gynecologist for cosmetic gynecology? Not just a certificate course. Do you agree with that?
Yes, of course. They have to take a good certificate course. They have to go. They have the ground, a good ground on doing to understand everything. And we conduct already these courses. And I really give all my experience. Not only my experience. I give them everything around the world. I bring it for them in the course, and it is a comprehensive course. So they take everything, but they have to start working on this information. They have to gain it. I think it's not by years only. It's also by the patients. How many patients you will see? If you see a lot of patients, I think you will gain a lot of experience. But with years, you will have a good experience and will be master it, inshallah.
Thank you so much.
Anything from any of the speakers who want to add? I encourage all speakers, please. There are few questions which are left, so please answer it. We'll keep the webinar for extra 5 minutes. So if you have any questions, anything you want to answer, especially for Dr. Salwa or for the last 2 speakers, so please answer it in the question and answer so the people can get benefit of it. At the end of the webinar, I would like to thank everybody. I would like to thank all the speakers. I would like to thank Bayer for their support. I'd like to thank Cure. I'd like to thank Rose Al Jazeera. And on the top of that, Top House Conference for their actually organizing this webinar and their conference and the video they are doing and communication with all the participants. On the same time, I'd like to thank Al Mishari administration for the CME, which is 8 CME. I would like to thank Saudi Medical Specialization. I would like to thank Prof. Hassan Abdel Jabbar from Saudi OB-GYN Society, the president for their help and support. On the same time, special thanks to Dr. Mahmoud Yamani, who is supporting us. And you see from the number of speakers coming from Medina Munawwara. So we have a lot of participants from there and participants from all over Saudi Arabia, reaching to above 3,000. Thanks to Dr. Jihan Al-Hazmi for their help with us. So thank you very much for everybody, and Ramadan Mubarak. And I leave for Dr. Jihan if she wants to talk anything, because it's our pleasure that she joined us.
Thank you so much, Dr. Samir. I think whatever I said today, because we are so happy that that attendee is exceeding 3,000 even from outside Saudi Arabia. They called me that they are attending the webinar and they like the webinar. We hope that we have a lot of webinar like this with very great speakers with very great subjects, and inshallah we'll see you soon, and Ramadan Mubarak wa inshallah wa jazakum Allah khair. I like the speakers and the company and Al-Mishari Hospital, everyone participate in this webinar.
Thank you very much.
Thank you very much.
Thank you for all. Ramadan Kareem. Shall we leave?
But just only answer the last few questions if you have time, because question and answer. Just you press it and please answer, because there are some questions maybe for you. So just only press it and answer.
I don't find any question for me. Any question? I don't know.
إلا دكتورة سلوى في كثير أسئلة عن cosmetics.
طب هاتوا أعطوني إياها.
It's question and answer. Just you press it and please answer it.
حصلت بس مو أسئلة. في أنا تابع المحاضرة إيش اليوز of AMH ما في.
Yeah, you go down, you will find something.
Okay, down.
Okay. Yeah. Thank you very much for everybody. I think Salwa will be the last one to answer the question. So we'll keep the webinar open for extra 5 minutes until she will answer. And also it's present in the YouTube. So anybody who like to see the lectures, to hear it, it's present also in the YouTube. And I think because the number exceed 3,000, so the YouTube was open for extra participant. Thank you very much.
في هنا سؤال مكتوب دكتور سلوى suggests cosmetic courses, how can we learn about it? في احنا بنعمل هنا عن تحت مظلة we do the cosmetic courses now under the umbrella with Dr. Hassan Abdul Jabbar, under the umbrella of Saudi Society, and it's really amazing, and we will do inshallah with Dr. Samir والدكتور سمير Al-Mishari Hospital. صح دكتور سمير?
It's our pleasure, yeah, to join you. You'll be the leader.
No, I'm the leader. I don't know how you will know about it. Follow my Instagram. My Instagram, Dr. Salwa Bahkari, and I already put there the cosmetic courses. And really, if you attend that course, you are the winner. You are not loser. Anyway.
Thank you. Take your time, just you answer it by writing, I think, so it will be better. So just only answer it, so that an answer will be there, and you will just type answer live, please.
Type answer, okay.
Okay, so take your time, we'll give you extra 5 minutes. The webinar is open, so keep it. I think you'll be the last one to leave the webinar. Thank you very much, Dr. Salwa, and I'll say Ramadan Kareem for everybody, and see you in the next webinar, inshallah.
Inshallah.
Inshallah. Thanks to Dr. Jihan, to Dr. Mahmoud Yamani, and to everybody. شكرا يا بروف حسان على جهودك, الله يعافيك إن شاء الله. And thanks to our senior lecturer, Prof. Dr. Haj Maroof and Dr. Abdul Aziz Al Abeid and Dr. Rihab, and all the speakers who are joining us, Dr. Mahir, Dr. Muhammad Mabrook. It's our pleasure that they join us, and Dr. Shadia from Maryan, Habib, and everybody who join us. It's our pleasure that they are with us. Thank you very much, and see you soon, inshallah, in the next webinar, and we hope we'll meet soon, inshallah, after Eid, inshallah.
There is one question, Dr. Salwa, is it an expensive procedure? It depends on the procedure, depend on whatever you use, depend on the center you work, depend on the country, and usually I like combination therapy. Not only one therapy. So the combination means many procedures. So many means more money. But usually I depend on, I tell the patient what she needs, and I tell her my priority, and I discuss with her. You have to discuss with the patient. And the most important thing in cosmetic gynecology, you have to give the realistic information to the patient, expectation. don't give the patients a lot of promises, because she will raise her expectation and she will not be satisfied with your result, even if you do a great job. And this is one. What else? Where is the other? Thank you, Dr. Salwa. Please, how do you address cultural issue? Cultural issue also, how do you address cultural issue, and what do you advise as best way for issue preservation in your gynecological cosmetic? For me, when the patient come to me, I have to gain the trust of the patient, because a lot of patients, when they come for something, but they have, as I said, hidden agenda. So I'm speaking with them, and I build the trust between me and them. I take a long time with the patient. Then they feel relaxed and they speak. And many patients, they do a lot of depends on many patients. They did a lot of these cosmetic procedures without knowing from her family or husband. They do it behind her husband. She wants her husband to think that she's become beautiful like this alone. So those okay. But I'm trying now to, to aware the people, and always I'm speaking in media, always I'm speaking that this is, a lot of people, a lot of females, they go and they do cosmetic surgery, fillers, botox, everything on the face. And the face, and they feel that if they do these procedures on the genital area, this is like they feel inferior or something bad, that she's not feminine. But I try to change this concept, and I try to change this idea. And told them, if you do something for the face, you do it for everyone. Everyone will see you, everyone who's conserve it or deserve it or not deserve it. But if you do something in the genital area, you just do it for who? You just do it for one person. You just do it for your husband. So this is a private. So you have to be confident. You have to be proud of yourself, because you care about your life. So we have to change. This idea. Are extensive courses of 5 days in IVF and cosmetic gynecology sufficient in order to practice it? No, it is not sufficient, but you have to work always in my courses. I told I always after I make a workshop and train them, I told them, try to work on volunteer. Don't start doing any work with real patient. There is a lot of company, they usually attend the courses or the conferences. You can take from those company, you can buy yourself, you can buy from them the material. It will be less with less money, or also with discount, and you bring volunteer and do it for them yourself. And you can ask anyone who is expert to be with you. Okay. And how can you after? I think I finished my questions.
Yeah, thank you very much, Doctora, and you can leave. And thank you very much for everybody. They can leave. Thank you very much.